Hello. So let's start our today's session. Today's session is going to be a really, a really great session because we are going to discuss, to be honest, the physiology section of your pulmonary system basically involves a lot of concepts from physics, to be really honest, right? Like the pressure, we'll be discussing about, we'll be moving towards our basic physics laws, a lot of principles. So I want you guys to be really interactive. Just turn on your mic. If you do have any issues, just stop me and ask me why. Okay? Because once you know the physiology, the physiology you can just relate it with the physiology of your cardiovascular. That the cardiovascular also involves a lot of concepts from physics, the parallel circuits, the series circuits, how the resistance is going to be changed, what would happen to the pressure and everything. So this physiology is also considered to be one of the toughest physiology, and believe me, we are going to make it really easy for you guys. And Dr. Muaz is also going to join in a while, but before that, I'll just take the session and I'll just continue the discussion today, okay? So if you guys have any problem, just stop me there and just ask me, right? So we'll be starting from lungs embryology, right? Lungs, how do lungs develop, right? Can you guys just see my screen? Hello?
Yes.
Okay, that's perfect.
Yes.
Perfect. Okay, so we are going to discuss lungs development, right? Lungs development. Okay. So the first question should arise in your mind that how do lungs develop? That's really an important concept, and there are a lot of pathologies associated with this process. If you have failure of that process, it's going to lead to a really important pathologies, and believe me, you are going to see that on your exam day. Like there are a lot of MCQs in your NBME 28, in each and every NBME regarding a topic which we'll be discussing, that is TE fistula, right? So imagine that, first of all, for example, if this is your esophagus, right? So embryologically or primitively, what happens that esophagus is going to give rise to an outgrowth, right? And we know that whenever we have an outgrowth, we call it as a diverticulum, right? Can you just please fix your mic, Dr. Felix? Dr. Felix, can you please fix your mic? Okay. Hello? Okay, thank you so much. So primitively, your esophagus is formed, right? And esophagus is basically going to give rise to an outgrowth or a bud or a diverticulum, and that diverticulum is going to be called as respiratory diverticulum, right? You can simply imagine it as a balloon, right? A balloon which isn't inflated. So in order to inflate this balloon, so we need a stretching force as well, right? We need to blow inside this balloon in order to stretch this balloon, and in the end we can get a big, big lungs with a lot of airs within that. So that stretching force is basically provided by your amniotic fluid. Amniotic fluid, right? We know what is amniotic fluid. We already discussed in Potter sequence. You guys would be having a better idea of that. That basically your fetal kidneys are going to make urine, and this urine is basically going to be called as amniotic fluid whenever it's present in the yolk sac, okay? So what the baby is going to do, it's going to swallow this fluid, it's going to swallow the fluid, and the baby is also going to aspirate this fluid. So aspiration of this fluid is going to give the stretch to baby's lungs, and in the end we are going to be having development of big lungs with a proper channels, trachea, bronchi, bronchioles, with proper alveoli. So that stretch is basically provided by amniotic fluid. So we discussed in our renal section, if you guys remember, whenever we have failure of kidneys to form, we won't be having proper urine formation, we won't be having amniotic fluid, and we won't be giving that stretch to the lungs in order to develop, right? So what would happen? It's going to lead to lungs hypoplasia. If you guys remember, that was one of your UL MCQ as well, right? So as the baby aspirates this amniotic fluid, your lungs or this diverticulum is going to expand in a properly way, and that stages which involve the development of lung can be remembered by a mnemonic, which is every pulmonologist can see alveoli. So the first stage of development of this respiratory diverticulum is going to be called as embryonic stage. The embryonic stage basically, it occurs at the 4th week till the 7th week. It's really important to know the structures which are formed during embryonic stage, right? Which occurs from 4th week to your 7th week. So which structures are going to be formed? We are going to have formation of your, yes, anyone who can just help me with that. That's a pure memorization, right? You will be having development of trachea, the bronchial buds, along with that the main bronchi, right? The right and left bronchus. Then the bronchus is going to enter into lobes, right? You have different lobes of your lungs. You guys know that, right? So let's call that as a lobar bronchi or secondary bronchi, right? So then we are going to be having lobar bronchi. They're also known as your secondary bronchi. Then furtherly, it's going to be distributed in lobules, right? Or in the further small segment of your lung. So let's call it as segmental bronchi or tertiary bronchi, right? So segmental and tertiary bronchi. These are the structures which are going to be formed during embryonic phase of your lungs development. Okay, so how your NBME is going to test you regarding this concept? That's very easy, right? Can you guys just tell me, do we have, okay, where do the gaseous exchange occur? Can you guys just tell me that? Where do the gaseous exchange
At
occur?
alveolar level. Alveoli?
Perfect.
Alveoli.
Alveoli and respiratory bronchioles, not only alveoli, right? Because the small bronchioles, the respiratory bronchioles also is having a capillary network which is able to undergo the proper gaseous exchange process. So what kind of MCQs are you going to see regarding this concept? We have a baby, he was born 4th to 7th week. Is he capable of breathing? Yes or no? No. Is he capable of survival? No. Right? He isn't capable of survival because he cannot breathe. He do not have that gaseous exchange layer in order to undergo gaseous exchange, in order to properly expel out your carbon dioxide and take in your oxygen. But the common pathology which occur at this stage is going to be your tracheoesophageal fistula, which is really important pathology and really simple as well. It's really simple and it's really important. You must be seeing an MCQ on your real exam day from this topic, okay? So tracheoesophageal fistula. So what is tracheoesophageal fistula? There are 3 variants of this fistula, right? For example, we know that normally these are your esophagus and this is your trachea, right? Both of them are separate from one another. What do fistula mean? Fistula mean whenever we have connection between these esophagus and trachea. That's basically a connection, fistula, right? So there are 3 variants as I already discussed. The first variant is going to be, which we are going to discuss, is H type. You can see it's forming an H, right? It's your esophagus and your trachea. Okay, are you guys following me?
Yes, sir.
Okay, so, and the most common variant of TE fistula is going to be like this, okay? For example, this is your trachea. So what would happen in the most common variant is that your esophagus is going to be ending as a blind tube. And the distal part of esophagus is basically going to be connected with the distal portion of your esophagus. So the trachea is going to be in connection with the distal portion of your esophagus, right? This is the most common. Okay, whenever we have a blind tube, what term do you use for that?
Atresia.
Atresia, right? So this is basically esophageal atresia with distal tracheoesophageal fistula, right? So this is the most common variant, and today we are going to focus on this mainly, right? We have H type, we have this process, and along with that we have another thing as well, that both of them are atratic, right? But today we are going to focus on this because that's the most common variant, and you guys are going to be asked a lot of MCQs regarding this topic, okay? So what would we see as an outcome of this condition, tracheoesophageal fistula with esophageal atresia? So as I already told you that the amniotic fluid basically is going to be swallowed by your baby and the fetus in order to have proper circulation of this fluid, of your amniotic fluid. Like the fluid is going to be made by your kidney, it's going to be your urine. What your baby is going to do, baby is going to either aspirate it in order to help in development of your lungs, and it's also going to swallow in order to have a proper a proper outflow for that fluid. So if we have atresia, so would this baby able to swallow all of the fluid? No. So what would happen as a consequence of that? Polyhydramnios, right? That is, all of the fluid is going to build up within that amniotic cavity and it's going to enlarge. Okay, so that's basically known as polyhydramnios. Is that right? Hello?
Yes.
Okay.
Yes,
What
sir.
else we are going to see? And okay, if this baby is like, if you are just passing an NG tube, right? So can we just pass NG tube in these babies?
No.
No, because as we are passing the tube, what happens? The tube is going to reflect back. It's going to reflect back. Okay. What else we are going to see? This baby is going to be having drooling of saliva, because as he's taking the saliva in, it's going to build up and it's again going to come back. Okay. Hello.
Yes, sir.
So these are going to be the common features which we are going to see in this individual. Coming towards the distal aspect, what we are going to see here, you guys know that here to the esophagus, your stomach is attached. So what happens? The HCl and the gastric content can move into your lungs, right? It can move into your lungs. And as it can move into your lungs, can it lead to aspiration pneumonia?
Yes.
Yes.
Yes, it could lead to aspiration pneumonia. And if we are suspecting an individual with aspiration pneumonia, so which bugs are we going to see in that case? Really important, really high yield.
Klebsiella, Burkholderia,
Okay, bacteroids,
bacteroids, yeah.
fusobacterium, right?
Fusiform, yes. Fusiform bacteria, yes, exactly.
Yes. So these are going to be the bugs which will indicate that this pneumonia is due to aspiration. That is, things are refluxing from your GI tract into your lungs, right? What else can happen? The gas can just move back and it can enter into the stomach as well. So on imaging, can we see distended stomach? A bubble, a big bubble. Yes or no? Yes. So these are going to be the things which we are going to see in tracheoesophageal fistula. That is the most common variant, right? So just keep these things in your mind. So in your NBME 28, you have an MCQ. They're going to ask you that we have an individual with all of the signs and symptoms of TE fistula, polyhydramnios, drooling of saliva. You can easily diagnose it. They're going to ask you that it's basically the failure of which process? So it's basically a failure of the septum being formed in both of these structures, right? Is that clear?
Yes.
Yes, sir.
Okay. So, and this pathology is basically going to be seen like the chances of this pathology to occur is going to be more in your embryonic phase of your lungs development. Is that clear? So let's discuss our next phase, right? So every pulmonologist, for every it was embryological, pulmonologist, the P is pseudoglandular. Pseudoglandular. What do you mean by pseudo? The word pseudo. Pseudo means false.
False.
Right? So false formation of gland. Okay, so which kind of things are we going to see in this phase? Which kind of the structures are going to develop in this phase? That is your terminal bronchioles. Terminal bronchioles. Along with that, your alveolar ducts. And it's going to be surrounded by a capillary network, right? But a modest capillary network, not a highly capillary network, right? Okay. Do we have respiratory bronchioles here? Yes or no?
Yes.
No, we do not have
No,
respiratory
here
bronchioles.
not.
Right? We have only the terminal and we have the alveolar ducts. Then we are going to be having respiratory bronchioles, right? So you guys can see if a baby, okay, what's the time duration of this phase? That it occurs from 5th week to your 17th week. So your world is going to ask you a question. A baby was born at 16th week of development. Is he capable of survival? Yes or no?
No, 16 weeks.
No. He isn't capable of survival because he's incompatible with life, because you do not have the respiration possible, right? Okay, so the third one is every pulmonologist can. C stand for canalicular phase, right? canalicular phase. In this phase, basically the terminal bronchioles are going to be converted into respiratory bronchioles along with alveolar ducts. Okay, so alveolar ducts aren't seen here, right? Really sorry for that. Okay, we won't be seeing, we are only going to see terminal bronchioles, right? So the alveolar, the respiratory bronchioles, like you have your terminal bronchioles, then you have respiratory bronchioles. Respiratory bronchioles have a proper capillary network. So that's why the gaseous exchange is possible here, right? Then we have alveolar ducts and your alveoli, right? So these are the structures which are going to be formed, till the alveolar duct in this process, right? So if a baby is born at 20th, okay, so the time duration for it is 16 to 25 weeks. A baby is born at 20 week of development. Is he able to survive? Yes or no?
Yes.
No.
Yes.
Yes. We
Yes.
have respiratory bronchioles. We have this channel. We have this proper, capillary network, which can lead to survival of this baby. That's what you have to keep in mind. Okay. Every pulmonologist can see for saccular, right? The saccular phase. The saccular is really easy. You are going to see formation of sacs. So what are sacs? Alveoli are your sacs, right? Hello?
Yes.
Alveoli are just like sac-like structures. So these alveoli formation is going to occur at the saccular phase. And yes, a baby, okay, what's the time duration? After 24th week. If a baby is born after 24th week, is compatible with life. After that, we have the last period, which is basically your alveolar phase, right? So alveolar phase occurs from 36 till the 8 years of age. Like even after a baby is born till 8 years of age, this phase is going to occur. And what's the main goal of this phase? For example, if these are your alveoli, so a process of septation would occur here, right? So we are going to have formation of septation. So this single big structure is going to convert it into multiple structure, and it's going to increase the surface area for your gaseous exchange, right? So the surface area of gaseous exchange is basically increased during this phase. It's really important, right? Okay. Hello?
Yes, sir.
Okay.
Yes, sir.
This was all about your, your entire embryology. Hope so you guys have a better idea of it now. So let's discuss our next pathology, that is choanal atresia, right? That is choanal atresia. Do anyone have any idea regarding choanal atresia?
The obstruction or the blockage at the level of posterior neurons.
Okay.
Layer. Mhm.
Okay. Anything else?
Mm.
Okay. Do you guys have any idea regarding this pathology, choanal atresia?
Blockage of the nasal passage.
Okay, so the nasal passage are basically blocked. And how do they get blocked?
Entities cannot be passed.
Bone.
Okay, perfect.
It occurs
So,
in the bone and the soft tissues that separate the.
okay, for example, if this is your nose, right? So what happens at the posterior aspect of the nose, basically they are blocked. And how are they blocked? Basically, we have, the bony part of the, posterior nasal part, it do not get separated. So you are going to be having a pure blockage, right? And you can diagnose this condition immediately after the birth. Okay? And if we have bilateral choanal atresia, it's an emergency. It's basically an emergency condition. So my question for you guys is that if the choanal atresia is an emergency situation, right? So my question for you guys is that why is it going to be an emergency situation for us if we are able to breathe through mouth?
During feeding, I think.
Are the nasal breather.
Problems during feeding.
Okay, problems during feeding. Okay, we are going to have severe cyanosis, by the way, right? So the problem here is that keep in mind, all of the individual basically primitively are nasal breathers, right? All of us, we are nasal breathers. In order to breathe through your mouth, you need practice for that, yeah, right? You need a practice in order to, breathe through mouth. But whenever a baby is born, he do not have this practice of breathing through mouth. He is only able to breathe through your nose. right? So for example, if you're just passing, let's suppose an NG tube, right, nasogastric tube, let's suppose, or if you are just passing a tube, so what would happen again? It would reflect back, right? If you have any, if you have a kind of blockade here, right? So it would reflect back. So you can diagnose this condition like really quickly, really easily, right? Hello?
Yes, sir.
Yes.
Yes.
Yes,
So
sir.
as you if we have unilateral coronal atresia, that isn't any problem because the baby can still breathe through this single, nostril, you can just say. But if we have bilateral, that's an emergency because primitively we are nasal breather. The baby cannot breathe through the mouth. So what would happen? It's an emergency. You have to treat it as soon as possible, right? So the nasopharyngeal tube basically is going to come back, and the CT scan is going to tell you the definitive diagnosis that yes, we have some kind of blockage back in the nose, right? Okay. So basically, there is a syndrome which is known as Charge syndrome, right? We're going to discuss Charge syndrome in detail, but you can just remember that the coronal atresia is one of the component of this, right? So often a multiple malformation syndrome can occur, right? Along with that, like you can have atresia of the choana, heart defect, you can have restricted growth, genitourinary defect, and ear defects. We're going to be discussing that in detail in our next sections, right? But the coronal atresia is really important, and you should know. If a baby just come to you with cyanosis, with severe cyanosis, you are just passing a nasopharyngeal tube, it's coming back, right? It's coming back in both of the nostrils. It's an emergency. Why? Because he could not breathe through mouth, and we have blockade of that posterior nasal parts. Okay, that's something which you guys have to keep in mind. Is that clear?
Yes, sir.
Okay, so let's move to our next topic, that is lungs malformation. That's really important. Okay, lungs malformation. As we discussed that, for example, if this is your esophagus, so first of all, we are going to be having this outgrowth, respiratory diverticulum, and this diverticulum in the end is going to lead to formation of your entire lungs. But one thing which you should just keep in mind, for example, if we have proper stretch from the amniotic fluid to this diverticulum, but still we need some space for the lungs to grow as well. We need space for the lungs, right, in the thorax. Do we need that space? Hello?
Yes, we do.
Yes.
If we are distending this diverticulum, we need space for it to grow. But for example, if you do not have some space in the thorax, again, it's going to lead to lung hypoplasia. Am I right?
Yes.
Yes.
Yes, sir.
So condition which basically occupies spaces within the thorax is going to be congenital diaphragmatic hernia. So what happened in that case, for example, if these are your lungs in the thorax and this is your diaphragm, so sometimes what happens, we have for failure of a membrane. What's the name of that membrane? Really important here. Your world is going to ask you. Pleuroperitoneal membrane, right?
Yeah.
Okay. So if this membrane do not fuses properly, so what would happen? All of the content from your GI is going to herniate into your thorax. And now you are limiting the space. You are occupying the space within the thorax, and you are limiting the growth of the lungs. So would it lead to hypoplasia?
Yes.
Yes, it would lead to lung hypoplasia. That's right. Okay. So this is really important. Keep that in mind. So how are we going to diagnose this disease? First of all, one thing which you should just keep in mind is that whenever the bowel or the, let's suppose your small intestine, your large intestine, even for example, if the, let's suppose the stomach, it's herniating. So what happens, we are going to hear bowel sounds within the thorax. If you are hearing bowel sounds, if in the question stem, they're just telling you bowel sounds are heard in the thorax. So you should just imagine of this condition, because normally the bowel sounds aren't in the thorax, they're in the abdomen, right? It means that the bowel is herniating into your thorax, and you can just hear that sound. What else would happen? You are going to have, scaphoid abdomen, right? What does scaphoid abdomen mean? For example, if this is a baby laying down like this is his head. So what happens? His abdomen is going to be like that, and his chest wall is going to be like that. Okay. Why? Because if all of the contents are herniating upward, so you are going to see a concave kind of structures, right? That is basically known as scaphoid abdomen. Is that clear? Hello?
Yes, sir.
The
Yes.
structures are moving upward. It's obvious that you're going to have a concave structure whenever the baby is laying down, right? Because it would indicate that your abdomen is missing its content, right? So scaphoid abdomen is also really important. Okay, and what else? For example, if your stomach also herniates and we are just passing an NG tube, so the tube is going to be seen within the thorax, right?
Yes.
So these three things are really high yield. I would say really high yield, right? First of all, bowel sounds within the thorax, scaphoid abdomen, and angiotube seen in the
NG2.
thorax. And what's the main pathology? Failure of pleuroperitoneal membrane to fuse or to form. Okay. Hello.
Yes, sir.
Okay, I'll be just indicating this MCQ once we're doing UGOL discussion. From tomorrow onwards, I'll be doing the UGOL discussion daily with you guys. So you guys know that we are going to spend a lot of time on these things, and you're already going to see this MCQ in the UGOL. So there I'm going to ask you the diagnosis and everything, right? Okay. So the next thing is bronchogenic cyst. What is bronchogenic cyst? That's really important to know. Sometimes what happens, for example, if this is your esophagus and this is your respiratory diverticulum. So sometimes we can have formation of a cyst here in close proximity with your respiratory diverticulum, right? And as your lungs grow maturely, so what happens? This cyst, which is going to be filled with clear fluid, right? It's going to be filled with clear fluid. So sometimes what happens? It would lead to compression of your lungs structures. Does that make sense? If you have a fluid cavity in close proximity with your respiratory diverticulum, as it grows, it would lead to compression of your structures of your lung, right? Hello?
Yes, yes.
Okay.
Yes.
So,
No. Please, can you take it again?
okay. So let me just repeat it again. So, for example, if this is your esophagus, right? Normally, we know that we have our respiratory diverticulum. Sometimes in case of bronchogenic cyst, what happens that we are going to be seeing formation of a cyst in close proximity with this diverticulum, right? And as the lungs grow in size, this cyst is also going to grow in size. So as in the mature individual, what happens? It's going to compress your lung structures. Like for example, if it's in close proximity in your to your bronchi, it can compress your bronchi. It can compress the bronchioles, right? That's the main thing which I want to indicate. Like for example, if it's in close proximity with your bronchioles, it can lead to compression of your bronchioles, right?
Yeah.
Compression of your
Yes,
bronchioles.
sir.
And whenever we have compression leads to stasis, right? And stasis leads to infections, right? So what would be the main complaint of this individual? Yes,
Recurrent pulmonary infections.
recurrent pulmonary infections, right? So most of the life, like he won't be having any problem. Like it's basically diagnosed, accidentally, right? Like for example, if you're doing imaging for any other condition, or you're doing a chest X-ray, but incidentally you can just find this bronchogenic cyst. But yes, the patient with this cyst would definitely be having, complaints of getting recurrent pulmonary infection. If you guys remember, we have a same case in our renal section as well, with a complaint of recurrent pulmonary infection, recurrent renal infections. What was that? Something-
That is urachal cyst.
Yes, urachal cyst as well. Yes, but something related with your Down syndrome. Turner syndrome. Seen in individuals with Turner syndrome.
Horseshoe kidney.
Horseshoe
Or-
kidney. So, yeah.
Horseshoe-shaped kidney. Horseshoe-shaped kidney. That was the same kind of complaints which individual was, let's suppose telling to any physician. Okay, so that's very important. So the next topic which we are going to discuss is alveolar cell types, right? Alveolar cell
Sorry,
type.
Dr. Ahmed. Hello?
Yes, please.
Sorry, Dr. Ahmed. I didn't mean to take you back, but with the compression of the pulmonary area, stasis of what we will be having, because you said when there's formation of cyst here, it will compress.
Okay, let me just clarify this concept. For example, if these are my bronchioles and my bronchi and lungs, let's suppose if I'm compressing this structure, right?
Yes,
It's a kind of, I'm obstructing this place, right?
that is correct.
Okay, if I'm obstructing, so would the air completely leave the lungs?
No.
So we
Okay,
are going
so
to have
we'll have air
stasis of
trapping.
air.
We'll have air trapping. Okay.
Stasis or trapping of air, right?
Okay.
Air would stay. And whenever we have stasis anywhere, it's a good site for your bugs
Yes,
to
good
grow
one.
and cause infections.
Okay.
Is that clear now?
Yes, it is.
Okay, like same example we discussed in uretero-pelvic junction obstruction. If we have obstruction here, stasis of urine, and stasis of urine is going to lead to UTI or
Yeah.
your pyelonephritis in this case.
I think
Okay.
I was confusing is because I would normally think that stasis is used for fluid or fluid containing things. So when you said stasis, I thought you meant fluid, so I was confused because I
No,
knew
like it's stasis of air, right? Stasis of air.
I got
Okay.
you. Yes, I got
Okay.
it. Thank
Okay,
you.
perfect. Thank you so much. So,
Also, aspiration would be the most common thing in this patient.
sorry.
Like aspiration would be most common in these patients, like they left with bronchogenic cyst.
Okay, with bronchogenetics, we do not have chances of getting aspiration because aspiration would always be whenever the fluid is or the stomach content is moving backward, right?
Okay.
So that's basically aspiration of your GI content, right? But in this case, we won't be seeing any kind of aspiration. We're only going to be seeing stasis and the common bugs which can just cause pneumonia, which we are going to discuss in our pathology section in detail. Those are the bugs which are going to be responsible. We are going to discuss that, right, in detail.
Okay, sir.
The bugs. So
Thank you.
everything is going to be really clear for you guys. Okay. So the next topic which we are going to discuss is alveolar cell types. Really important and a lot of MCQs from here as well, right? So we have two types, you can say 2 or 3 types of cells which are basically present at the level of alveoli, right? Type 1 pneumocytes, right? Type 1 pneumocytes. That's really simple. What are type 1 pneumocytes? Really simple. The most abundant one, 97% of cells are your type 1 pneumocytes. And the nature of these cells are that they are very thin. They're very thin, very delicate. So whenever we have a thin media is very great for your gaseous exchange, right? Because whenever the diffusion barrier is thin, you can easily pass substances. We are going to discuss pathologies, for example, the restrictive lung diseases or pulmonary fibrosis. What happens in fibrosis, basically the diffusion barrier is going to become thick. As we have a lot of fibrous substances being deposited there at the level of alveoli, we're going to discuss how does that happen, the entire pathophysiology, right? We have a lot of pathologies related to that, like the coal mine workers and idiopathic pulmonary interstitial fibrosis and everything. But the main concept there is whenever the diffusion barrier becomes thick, it's very difficult for the gases to pass. So thin barrier is good for diffusion, right? Thin barrier is good for diffusion. So type 1 pneumocytes are very thin, so they are very better for diffusion, and 97% of them are of all of your pneumocytes are type 1 pneumocytes. So basically, they helps better in your gaseous exchange. Okay, and is that clear? Hello.
Yes.
Yes, sir.
Yes.
Then we have type 2 pneumocytes. Type 2 pneumocytes. They are really important, right? So the remaining like 2 to 3% are your type 2 pneumocytes. But type 2 pneumocytes are really important because it have like a really important functions. First of all, it's going to release surfactants. Right? We are going to discuss what surfactants are in a little while. But another thing which is really important, they help your lungs to regenerate. Okay, these are the two things which you should just keep in mind. Okay, and so you're going to be seeing an MCQ in your NBME. They are going to be asking you, we have an individual, he was having pneumonia and excessive damage to his lungs. After 2 to 3 months, everything was normal. Which cells types are responsible of regenerating your lungs? What should be your answer?
Yeah,
Type
type
2.
Okay, perfect. That's going to be your type 2 pneumocyte. Okay, it's also going to release surfactants, right? So let's discuss, before discussing what are surfactants, like, it's a really hot topic for your exams. So, but it's basically a topic from chemistry, right? So if you know the chemistry, if you know the molecules, their interaction, so I think this topic is then going to be really simpler for you guys. So let's just, discuss some chemistry. Just leave your, medicine for now. Okay, remember, for example, if I have a glass full of water, right? Let's suppose. So if you guys are seeing the surface of water basically form a meniscus, right? What is a meniscus? Meniscus is basically that it won't form a straight line always. It would just form a curved line on the surface, which is basically known as meniscus, right?
Yes, sir.
Okay, so why is that so? That's really easy, right? We know that if you guys remember from your chemistry, that H2O, water interact with water, they have a bonding which is known as hydrogen bonding, right? Hydrogen bonding, right? Are you guys aware of the covalent bond, the ionic bond, hydrogen bond? Remember?
Yeah.
From your
Yes,
chemistry,
sir.
yeah? Okay. So for example, if we have a molecule here, let's suppose let's take some molecules of water here, right? So if we have a molecule here, so this molecule is going to be attracted by the molecules on right side. It's going to be attracted by the molecules on left side. So it means that this force is going to be balanced and the molecule is going to stay in between, right? It's going to be attracted from the molecules from downside, but upside you also have some molecules, and these molecules are going to attract it. And so in that way, the molecule is going to stay on its own place due to balance of all of these attractive forces. Does that make sense?
Yes.
Okay. But if you see the molecules on top here, these molecules are attracted from the right side. These are attracted from the left side, that is balanced. These are attracted from the downside, but up there you do not have any molecule. So won't we be having, if you just add the vectors, you do know what are the vectors, right? From your physics. So if you add the vectors, so the end force is going to be pulling water surface downward because you do not have anyone here to balance that.
Yes. Yes.
Does that make sense? So that's why we are going to see formation of the meniscus. Okay.
Yes. Yes.
Okay. So basically, in all of the fluids, we have an attractive forces, and due to which the molecules attract to one another, right? So for example, let's just apply this concept to your alveoli as well. Alveoli basically have a layer of fluid, right? Alveoli basically have a layer of fluid. Okay, and this layer of fluid basically is having attractive forces, right? Attractive forces. Okay, and all of these attractive forces are basically, they are attracting towards one another. If we add all of these forces, so won't it lead to alveoli collapse? Because you guys can see all of the forces are, ultimately around structures, all of the forces are going to add in this direction. Does it make sense?
Yes.
Hello? Like it's going to be attracted from this side, attracting from this side, attracted from, but not from that. So if you add all of the forces, it means that these forces are going to tend to collapse your alveoli. These forces, which are basically formed by these fluid layer within the alveoli, in the end is going to collapse your alveoli, right? Is that clear?
Yes.
Okay. So for that, what should we do? We should just break these forces, right? We should just break these forces. Okay. So how do we break these forces? We are going to put certain substances which are going to come in between these molecules, and they are going to, decrease the forces, right? Decrease the attractive forces, which in the end is leading to alveolar collapse, right? So if I'm adding these molecules which are disrupting these attractive forces, so won't it decrease the chances of collapse, which I don't need, right? Collapse isn't good for me. I do not want my alveoli to collapse. So would adding of these substances decrease the collapsive force? Yes or no?
Yes.
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 Decrease the
Yes.
surface tension.
And what are these substances? These are your surfactants. Is that clear?
Yes.
Okay.
Yes.
Okay. Okay. So here we were discussing that the force which is basically, leading to the meniscus formation is, let's just call this force as surface tension. Surface tension. On this surface, we are having a tension which is pulling it towards down. So let's call it as surface tension. Can I call it as surface tension? A surface tension, a tension or a force on the surface which is pulling down the surface. So let's call it as surface tension. That's very simple. Here, the force which this surface is having, again, is going to be called as surface tension. Right? So can I say that surfactants decreases the surface tension? Can I say that?
Yes.
Can I say that the surface tension can cause alveolar collapse?
Yes.
Yes, right? So in order to decrease your surface tension and decrease alveolar collapse, surfactants are really important there, okay? They're going to be placed in between all of these particles, and they're going to decrease the surface tension and decrease alveolar collapse. Is that clear?
Yes.
Yes.
Okay. So another thing, you know that you have your lung recoil, right? What is lung recoil? For example, if this is an elastic substance, right? If I'm just pulling off this elastic substance, so what its elasticity is going to do? Its elasticity is going to lead to, again, bringing this elastic rubber towards its location, right? So that's basically known as a recoil or elastic recoil, right?
Yes.
Remember, we know that this alveoli, it's a kind of balloon, right? It's made up of collagen. So that collagen also basically gives elasticity to the structure, right? Elasticity to the structure. And this elasticity basically love to collapse the alveoli, right? If I'm just extending the alveoli by putting it in a lot of air, like for example, you can just simply imagine a balloon. If I'm inflating a balloon by pulling an air, as I release the air, due to elasticity, the balloon is going to become small, right? It's going to expel out all of the air, right? So you should just keep this in mind. Elasticity also leads to lung collapse. These forces I'm going to discuss in detail tomorrow once we are just starting physiology. That's really important, right? So you should just keep two things in mind. Surface tension is a collapsive force. Elasticity is a collapsive force. Just keep these two things in mind, okay? And that makes sense. Is that clear?
Yes.
Okay. So these surfactants, as we discussed, are made by your type 2 pneumocytes. And what these are going to do, they are going to decrease the alveolar collapse. They are going to decrease the collapse. They are going to decrease the surface tension. Okay, let's discuss another thing as well. So everything is going to be really simpler then. Do you know what is compliance?
Tendency to
Expand the lungs, meaning the
ability to expand.
increasing the
to
diameter.
expand. Yeah, to expand.
Let me just make it very easy for you guys. It's basically the ease of anything to distend, right? For example, if I have, let's suppose, a shopping bag, let's suppose, right? I can easily distend it, right? If I'm just blowing a little bit air, it's going to, it's going to distend. On the other hand, if I have a balloon, right, full of rubbery materials, so it's a little bit hard for me to distend it, right? So the compliance of a balloon is more of a compliance of a shopping bag is more.
Balloon.
It's easy for me to distend the shopping bag, or it's easy for me to distend the balloon.
Shopping bag?
Yes, it's easy for, yes, shopping bag. It's very easy for me to just blow a little bit air and it would stay there. But in order to distend a balloon, I need force. So the ease to distend anything is compliance. So the compliance of the shopping bag is more, the ease of distending shopping bag is more, or the ease of distending your balloon is more.
Shopping bag will be more.
Shopping bag is more. So can I say that shopping bag is more compliant than the balloon?
Yes.
Yes. Remember, compliance is inversely proportional to your elasticity.
Oh, yes.
Okay? Inversely, what do I mean by that? If a thing is, if let's suppose shopping bag, a shopping bag is made up of plastic, right? And simply you can imagine that your balloon is made of rubber. Plastic is more elastic or rubber is more elastic?
Rubber.
Rubber is more elastic.
So the more the elasticity, okay, sorry. What happens to my rubber? Okay, so this is your rubber. Okay, it's more elastic as compared to the plastic. So the more the elasticity, the lesser the compliance. Can I say that?
Yes.
Yes.
Okay, so the lesser the elasticity, more is your compliance. Does it make sense?
Yes. Yes.
No, can you repeat how?
Come
How
again,
is it
please.
more compliance?
Okay, no problem, no problem. Okay, for example, if you have a shopper, right, or a shopping bag, shopping bag is just like that. Okay, it's made of plastic, right? And we have a balloon. Okay, both of them are inflated, they do not have any air. If I'm just telling you to blow air in the shopping bag and just stand it, and at the same time I'm telling you to blow the balloon, would it be easy for you to blow the plastic bag, or would it be easy for you to blow the balloon?
Plastic bag.
Plastic bag. So if it's easy to to fill the plastic bag with air, so what's going to be the compliance?
Increase.
Increased.
Increase compliance. What was compliance? The ease of anything to distend, the ease of anything to stretch.
Okay.
So it's more easy.
Yes,
It's
in the
more
lytic
easy.
cardiomyopathy. Yeah, yes.
It's more easy. If it's more easy, it's more compliant. Right? Hello?
Yes, sir.
Yes, sir.
Then just compare it with balloon. So is it easy for you to distend a thick rubbery
No.
balloon? No. So can I say that it's not easy for me, it's a bit hard for me to distend the balloon, so the compliance is basically decreased. It's less compliant, right?
Yes.
Okay. And I already mentioned that. Okay, so can you just tell me the elasticity of your plastic bag is more, or the elasticity of your balloon is more?
Balloon is more.
Okay, so balloon have more elasticity because it's made up of rubber, and it have less elasticity because it's made up of plastic. So as we have now, okay, we have made the equation already, right? So can I say that compliance is inversely proportional to elasticity?
Yes.
Yes.
Because the more the elasticity, the lesser is your compliance. You can evident it here. You already derived the equation. You guys have derived the equation. See? Okay. The lesser the elasticity, the more is going to be the compliant. That's simple. I've just put a mathematical form of that. Okay. So now let's discuss. What does the surface tension do to your elasticity? Let's just take things a little bit further.
It increases the
Decreases.
elasticity because the surface tension is applying the force inward.
I'm
Decreases.
asking
It
about
decreases.
surfactants, not surface.
If we increase the surface tension, the elasticity will increase, means tendency to collapse increase.
Perfect. As we discussed, if you guys remember, elasticity is going to collapse your lungs, and surface tension also collapse your lungs. Both of these forces go in same way, right? So as the surface tension increases, it means that I'm increasing the elastic forces. And both of these forces basically are going to collapse your lungs, right?
Yes.
So can I say that as the surface tension increases, elasticity increases? If the elasticity increases, what happens to compliance? Yes.
Decreases.
Inversely relation.
Decreases.
So increases, elasticity increasing. So what happens to compliance? Inverse relation.
Inverse relation
Decreases.
decreases.
Yes. Lungs
So
cannot expand.
compliance
Yeah.
is decreasing. But when I'm giving surfactants, what would surfactants do to compliance?
Increase
Increase the.
Surfactants reduce the surface tension.
Mm-hmm.
So when the surface tension will be reducing, it means the
Compliance will increase.
compliance will
Perfect. Compliance is
Yes,
increasing,
compliance will
right?
increase. Yeah.
So what do increased compliance mean now? In order to distend, okay, it's now easy for you to distend your lungs. That's so good for you, right? We do not need enough force to distend your lungs. If we were needing a lot of force for your lungs distension, like for example in fibrosis, right? In fibrosis, what happens to elasticity?
Elasticity decrease.
Decreases.
Increases.
Increase.
I'm adding a lot of fibrous substances. I'm adding a lot of elastic substances. So what happens to elasticity?
Increased.
Elasticity increase. What happens to compliance?
Compliance decrease. Because
Compliance decreases. It means it's hard for me to blow the lungs, right? Can I say that? It's hard for me now in the pulmonary fibrosis. It would be hard for me to blow the lungs,
Yes.
right? It means I'll be using a lot of ATP. Hello?
Yes.
If I'm using a lot of ATP, it means I'm using a lot of energy. Even like whenever I'm sitting, I'm using a lot of energy. So won't an individual with pulmonary fibrosis be a thin individual with less fat content? Just think of it.
Yes.
Yes. Okay, because he's using a lot of energy even while breathing as compared to a normal individual, right? Hello?
Yes.
Yes.
So these are all of the things which you should just keep in mind. And you guys are, a lot of students get confused in what is compliance, what is elasticity, what's the relation, what's this and that. I think for you guys now, if you even do not remember these things, using your brain, you can just solve a lot of MCQs. And you are definitely going to have a lot of MCQs. And most of the students, get these kind of MCQs whenever they have mathematics, they get confused and things, right? So I think now it's really easy. We discuss physics, we discuss chemistry and everything in order to clarify this concept. Okay, so let's just take our discussion a little bit further. Okay, so what is surfactants? Now only we know the function of surfactants, we know from where does it come. Now the last part is the name. What's the name? It's a big name, right? Let's just call it a big name, right? Dipalmotyl sulfatidyl choline,
Lecithin, sphingomyelin.
right? Or lecithin or sphingomyelin, right? So in order to look for, so this ratio lecithin to sphingomyelin or sphingomyelin to lecithin ratio is also going to tell you the health of lungs as well, right? If a baby is growing, right? If a baby is growing, and we want to look for the, hello? Okay. So for example,
sir.
if you have a baby in fetus, right? And I want to know about his lung status. It means I should know about the surfactants development, right? That's basically going to tell me the lung health, right? For that, I have to look a ratio, right? That is basically lecithin to sphingomyelin ratio, right? Lecithin to sphingomyelin ratio, right? And these are basically the component of your surfactants. When the lecithin to sphingomyelin ratio is greater than or equal to 2, it means that the lungs are healthy. Keep that in mind. Whenever it's less than 2, 1.5, it means that the lungs aren't healthy. We have lesser formation of surfactants. And as, for example, if a baby is grown with less surfactants, obviously his lungs are going to collapse because the surface tension is going to dominate. We do not have the particles to disrupt the forces between molecules. So his lungs he's going to be in a respiratory distress, right? Hello?
Yes.
Yes,
So
sir.
let's call this condition as neonatal respiratory distress syndrome. Whenever we do not have proper formation of surfactants in a baby, that's simply known as neonatal respiratory distress syndrome. So for that, you should know that what helps your surfactants to produce, what helps your surfactant to grow well, right? That's really important. Okay, one thing to keep in mind, glucocorticoids. Glucocorticoids help to produce your surfactants. Keep that in mind, okay? What else? Hello? Okay. So let me just give you a scenario of one of your UL scenario. When are the glucocorticoids basically released? It's a stress hormone, remember? It's basically the same cortisol. Cortisol are your glucocorticoids, right?
Yes.
And they are your stress hormones.
Yes.
Right? So it's going to be made during stress. So you know that, whenever a mother is giving birth to a child, it's a really stressful situation. If it's a vaginal path, right? So in that stressful situation, we are going to be having a lot of release of glucocorticoids, and this increased surge of glucocorticoids is going to help excrete your surfactants and proper formation of on synthesis of your surfactant. So for example, if a baby is born via cesarean section, would he be having this exposure of increased glucocorticoids?
No.
No.
No,
They are
because he
having
do not have that stressful situation. He
transit.
won't be having this increased cortisol surge. If you do not have this increased cortisol surge, so can I say there is more chances of this baby to have neonatal respiratory distress syndrome or less surfactants?
Yes.
Yes.
Right?
More
This
chances.
is going to be a scenario for you guys in your NBME 28. Okay, keep that in mind. Okay, so this was all about the surfactants and alveolar macrophages. Then, so in the okay, we know the alveolar. Before discussing alveolar macrophages, can you guys just tell me what are your heart failure cells? So now you guys are going to be telling me what are alveolar macrophages. We discussed cardiovascular section. Do you guys know what are heart failure cells? Macrophages, right? And those macrophages were your alveolar macrophages, right?
Yes.
Yes, right. So, like for example, if you have heart failure, we are going to be having pulmonary edema, increase. You are going to be having increased capillary permeability. Blood, blood is going to move back, and your macrophages are going to eat them. They're going to lead to formation of hemorrhagin-laden macrophages. So it means that at the level of alveoli, we have macrophages as well, alveolar macrophages, right? And what's the function of
Yes.
macrophages? Macrophages basically
And
they are
your stuff
component of
phagocytes. Yeah.
phagocytes, immunity, they provide immunity, right? We are going to discuss this in our one of pathology, which is emphysema, right? So emphysema, we are going to discuss the detail of alveolar and the function of alveolar macrophages, the different enzymes and the disruption and everything, okay? So neonatal respiratory distress syndrome, we already discussed what is neonatal respiratory distress syndrome. We know that. It is basically lack of surfactants at birth, right? So if you have, okay, when do it occur? In C-section, okay, a mother having diabetes. So remember, the diabetes, increased glucose can also disrupt the formation of your, yes, what? Surfactants, right? So what is going to be the treatment? Treatment is very simple. Can you please fix your mic, Dr. Saad? Okay. So treatment is going to be really simple. Just give them glucocorticoids. The glucocorticoid is going to trigger the release of surfactants, right? We can give therapeutical oxygen supplementation as well. But the problem with therapeutical oxygen supplementation is, okay, this is also really important, right? What is going to be the problem if you are just administering a lot of oxygen? You know that oxygen can form free radicals, right?
Oxygen toxicity.
I have a question, doctor. I have a
Neonatal
question.
retinopathy.
Yes, please.
That in every patient, meaning in every C-section, whether it occurs at term,
Most,
we should give glucocorticoids.
But
Yes,
the diabetes only.
for
To the
maternal
every patient.
diabetes, okay, sorry. For maternal diabetes, we are going to give glucocorticoids, and if it's a C-section, we can just directly administer surfactants to an infant, right?
To every child.
Yes,
To
like
every
every child who is having this condition, neonatal respiratory distress syndrome, we are going to just give surfactants, right, in the lungs. It's going to help them reduce the surface tension, okay?
Or it are okay.
Okay. So, and glucocorticoid administration is also going to help this condition, okay? Okay, if a baby is in a distress, right, it means that you will be hypoxic, right? You will be hypoxic, okay?
Yes.
In order to treat hypoxia, we are definitely going to give some oxygen supplementation, right? 100% oxygen, for example. But if we are giving 100% oxygen, there is a problem with that. We know that administration of oxygen can lead to formation of free radicals, right? And free radicals are really dangerous for your body. Like these free radicals can just react with a lot of normal tissues, and it can cause problems. So, for example, retinopathy of prematurity, a common complication of a baby having neonatal respiratory distress syndrome treated with oxygen supplementation. Really important and really high yield. We're going to discuss this in ophthalmology section in our neurology. So you should just know this concept before that, okay? So in neonatal distress syndrome, you're giving 100% oxygen. It's going to lead to formation of free radicals. Free radical can just, damage the retina of baby, which is going to be called as retinopathy of prematurity, a common complication of individual or a baby with respiratory distress syndrome treated with oxygen supplementation. I have repeated 2 times because it's really high yield. You are going to see a lot of MCQs in UWorld as well. Okay, intraventricular hemorrhage, right? So in the brain, in the ventricles, it can lead to hemorrhage as well. Bronchopulmonary dysplasia. We are going to discuss bronchopulmonary dysplasia in our pathology section. There's a really interesting, pathology, and you are also going to be having MCQs in your world as well. Okay, so that was all about your respiratory embryology. Hope so you guys enjoyed. Okay.
Excuse me, sir. You mentioned the hemorrhage. It's
Yes, doctor.
because of is this diabetes, maternal diabetes, like the cause. I'm not getting
So
the last point.
okay, the last point was that whenever a baby is having neonatal respiratory distress syndrome, we are going to give 100% oxygen because the baby is in distress. He's hypoxic, right? But there are some side effects of 100% oxygen supplementation. What are those side effects? These 100% oxygen can form free radicals, right? Free radicals. If you guys remember the chemistry, what are free radicals? Free radicals are, any kind of elements with a lone pair of electron, remember?
Yes, sir.
And if whenever we have a lone pair of electron with any kind of atom, it's a highly reactive species. It would just try to react with
Yes.
anything in order to get an extra electron, right? So whenever we have free radical formation due to oxygen supplementation, so what happens? These free radical is going to react with something in order to get stabilized, because all of the nature, basically the main goal of the nature is to become stabilized, right? We are just giving our exam to be more stabilized. We are just doing stuff to get stabilized. So this electron is going to this atom is going to interact with a lot of tissues inside your body in order to get stabilized. But in that scenario, they are going to cause damage to the tissue. So they can just react with the retina, they can cause damage there. They can react with some of your brain ventricles, with some of the surface. They can just rupture the blood vessel there. It can lead to hemorrhages. They can lead to reaction. They can just cause that they can just react with your lungs parenchyma, leading to bronchopulmonary dysplasia, right? So these are the main concepts which you should just keep in mind. Okay.
Okay, sir.
Okay, so we are done with our embryology, and now we'll be discussing our anatomy, right? So before discussing our anatomy, let's have 5 minutes of break. Okay. Hello.
Okay, sir.
Okay, thank you.
Let's have 5 minutes of break, and then we'll be discussing our embryology section.
Thank you so
So-
much.
Sir, can you upload the yesterday's recording? As I already mentioned that I'll be just sharing. Okay, I'll be sharing the recordings because today I was having an issue with my Mac. So I just fixed it today. I was just there in the shop and fixed the screen, so I wasn't able to, share the recordings. So today I'm going to share that. Really sorry for that. Thanks a lot. Thanks a lot. Hello.
Yes, sir.
Okay. So let's continue our session from respiratory anatomy. Dr. Moaz is also going to join soon after 10 minutes, and then he's going to continue the discussion. Okay. So today we are going to cover a lot of things. So just stay here. Okay. We are also going to discuss, some of the physiology as well. Okay. So let's discuss our anatomy, right? So anatomy is very simple. We know that we have two zones, conducting zone and respiratory zone. Only looking towards the name, you guys are going to be telling me what is conducting zone and what is your respiratory zone. Yes.
The conducting zone is the part of the lung that takes the air to the area of exchange, and the area of exchange is the respiratory zone.
Perfect. So can I say that the conducting zone is only conducting the air? It do not have any, it do not have any ability to undergo gaseous exchange. Can I say that?
Yes.
Okay. So so can I call it as a dead space?
Yes.
Okay, what is dead space? Just keep this thing in mind. We're going to discuss dead space a lot, right? Like in a conditions, for example, pulmonary embolism is going to create a dead space for you guys. So let's discuss what is dead space. Anything, any medium in which we have a lot of gas, but we cannot exchange that gas, right? That's simply called a dead space. For example, we know that we have trachea, right? Trachea is made up of your cartilages, right? Cartilages or the trachea normally have a lot of air supply, but the trachea isn't able to undergo gaseous exchange. So let me just call it as a dead space. So till your respiratory, bronchioles, everything above that is your dead space. Can I say that? Hello?
Yes.
Yes, that's a dead space. But what is the function of dead space if it isn't, if it isn't able to if it isn't able to undergo gaseous exchange, then what's the function? Okay, here I'm going to point out an interesting thing as well. Okay, an interesting example regarding the dead space as well. So please just get your concentration here to dead space. It's not that simple as the first I mentioned that it's a dead space. There are a lot of implication of dead space as well, right? So what's the function of dead space whenever if it isn't able to undergo gaseous exchanges? Remember, if these are your lungs, right? So the first air which your lungs take are the air which is present in your dead space, right? Which is present in your dead space. So basically we have gaseous exchange in the dead space. Can I just say like that? We have gaseous exchange in the dead space. Your lungs are going to take the gases from the dead space, and it's going to expel the gases in the dead space, right?
Yes.
Okay, it's really important. So what's the function of dead space? Basically, it's going to humidify the air. It's going to warm the air in order to avoid that damage to your lungs parenchyma. So that's basically the importance of the dead space. Okay. So let me just ask you a question. For example, if I have an individual, right? Okay, so there was an individual. Once a really interesting idea came to his mind that let's just dive into a pool and let's just connect a stick to my mouth and let's breathe through that, right? Okay, he dived into the pool and basically he just took a big stick, and he was breathing through, and he was just thinking that's simple. Let's just take the stick and let's, a kind of pipe or a stick, right? Hollow pipe or hollow stick. And let's breathe through that. I can just survive in water. That's a good idea, right? Hello? Hello?
Yes.
But an unfortunate event occurs. After 1 hour, he was dead. So you guys are going to be telling me why.
Increase of dead space, same like endotracheal tube or any pipe, it will increase the more dead space. Difficult to exchange the gases.
Perfect. Okay, so actually this person was just he didn't knew the physiology, he didn't knew the concept, and he was just thinking that I should just take a pipe and I should just breathe through that. But basically what he was doing, he was just increasing the dead space, right? If I'm adding an extra pipe, The pipe cannot undergo gaseous exchange. But as he was just taking air from this dead space, and he was just expelling out the air in the dead space, which was full of carbon dioxide. So in the next breath, he was just taking carbon dioxide, right? Hello?
Yes.
So he died.
Or it should be less than his tidal volume. That
Yes.
can be survived.
Yes. So we are going to discuss that in detail, but you guys should know the concept of dead space, right? So next thing is your respiratory zone. So what is respiratory zone? Any area within your lungs which is capable of undergoing your gaseous exchange, right? For example, starting from the respiratory bronchioles till your alveoli, all of them are capable of exchanging the air. So that's basically called as respiratory zone. Really important, right? So let's discuss a little bit of lung anatomy as well, and let's discuss the MCQs which you guys are going to be asked regarding this lung anatomy, which is really important. Okay, so the right lobe basically have how much lungs? Lobes, sorry, right lobe. Right lung lobe have how much lobes?
3, upper,
Three.
middle, and lower.
Upper, middle, and lower. Perfect. That's also really important. Okay, but why? Because sometimes you are going to be having a pneumonia which is going to involve a single lobe, right? And on the imaging, whenever we have a single lobe involvement, so you are going to see a clear fissure, right? For example, if this is my lung, and let's suppose if I have a lobar pneumonia involving the upper lobe, so only this lobe is going to be having, we are going to discuss the characteristic features on the x-rays, and all of the lungs, down, or all the lobes are going to be normal sometimes in lobar pneumonia, right? So you are going to be having a clear fissure, which is basically separating your lung lobes. That's really important for you to diagnose diseases as well, right? So do not take it for granted that we have 3 lobes. So you can be tested on it as well in different aspects, okay? What else? The left lobe basically have how much lung? The left lung basically have how much lobes?
2.
2 upper and lower.
Because due to placement of the heart, the middle lobe isn't present, right? Okay, so now it's a really important. Okay, so let's discuss this concept, which is really important, and it's going to be highly tested on your UL as well. For example, if I have an individual, he's in supine position, right, and he's having some aspiration pneumonia, right? So the fluid is going to go into which lobes of his lungs or which areas of his lungs? That's
Right
really
lung.
important.
Right, it will be right lung.
Right lower.
Okay, first of all, the right lung more into right lung or more into left lung?
Right.
Right.
Why?
Because
Why more?
two things. First is the bronchus size, main bronchus after carina. The main bronchus size is larger, and the
Yes,
angle
it's
is also
having a
less.
greater diameter, and it's having an
Angle
angle.
also less.
Yes, the angle is really less, so it's like more chances of getting fluid or any foreign body into the right bronchus. That's really important, right? And as a person is supine, he's sleeping, right? So what happens as he's sleeping? So which lobes of the lungs are going to be affected? Yes,
Middle lobe.
Right lower.
Middle also.
the middle lobe,
Right lower lobe.
Right upper या middle.
Right
Middle.
the
lower.
posterior. Okay,
Posterior.
posterior
superior
aspect of
fragment
your
of
right upper lobe
right
Yes.
lower.
Yes, could be. Yes.
and superior aspect of the
Right
lower lobe.
lower.
Right lower.
Superior
Right?
of the right
Lower.
lower
Okay,
and the posterior of the right upper.
posterior of
Right
right
upper.
Right.
upper and superior of
Right lower.
right lower. You guys have successfully covered one of your UWorld MCQ. They are going to ask you the same scenario, right? Okay, for example, if an individual is laying on the right side or if he's prone, so where do the aspiration is going to enter? Yes, while lying on the right side.
Middle lobe. In
Sorry,
case of prone.
Right side, right middle or right upper.
right upper lobe, right? That's going to be right upper lobe. And then if individual is standing upright, then
Right lower
Then
lobe.
always due to gravity, right lower.
Yeah.
Yes.
okay,
Right middle or right lower.
okay,
Lower.
okay. Okay, just give me 1 minute, please. Okay. Okay, really sorry for the disturbance. Okay, so whenever a patient is upright, the idea is really clear. First of all, it's going to be right lobe, and as he's upright, due to gravity, it's going to be the lower lobe. That's simple, right? So these are something which you have to just keep in mind, and so these are really important. You guys are going to be asked like that, okay? So the next thing is diaphragmatic or diaphragm structure. So before discussing that, can you guys just tell me that something keeps your diaphragm alive? That's a mnemonic. Which nerve?
Phrenic nerve.
Phrenic.
Phrenic.
And what are the nerve roots for the phrenic nerve?
3, 4, 5.
3, 4, 5
4,
keeps
5.
the diaphragm alive.
So
Main
C3,
three.
C4,
Main four.
C5 keeps the diaphragm alive, right? We're going to discuss the function of diaphragm in really detail. What's the function of diaphragm during your respiratory cycles? That's going to be our next topic. So in your first aid, you have like different insertion of vessels in your diaphragm. You should just do it by your own. That's up to your memorization, right? So I won't just spend time on that. And with this, our entire anatomy is finished. So let's have a little bit break because I want Dr. Moss to join in this physiology. He have just told me he'll be joining in some while. And if he didn't, so we are going to continue the section tomorrow then, okay? So before discussing that, can you guys just tell me that how's your preparation going? Did you guys enjoy the session today?
Yes.
Okay, that's great, okay?
Always.
It's great.
So thank you so much. Thank you. Okay, so we'll be starting the physiology, and the physiology is, again involves a lot of concepts from physics as well. So let's wait for Dr. Moss. If he joined, so that would be good. If he didn't, then I'll be continuing the session. Okay, so let's have 10 minutes of break. Okay, really sorry for the delay, but you know that you have to. Okay,
How many minutes, doctor?
just 10 minutes. Just let's wait for 10 minutes. If Dr. Moss is joining, that's good. If not, then I'll just continue the session.
No, Dr. Hamilton?
Sorry? Yes.
Do we still have plans for Discord? Is Discord ever going to continue, or I don't know?
So as I already have mentioned that Discord sessions are basically for your own practice, right? It's open for you guys. Like in the first days, I already mentioned I was there in order to keep you guys, consistent with those sessions. But please, I want you guys to continue those sessions. Some days I'll be joining because, once everything is fine, I'll be just trying my best to join those sessions. But in the beginning, as I already mentioned, it's for your own discussion. So please just continue the discussion. You already have mad groups. You can just find study partners. Dr. Mariam is going to be your mentor there. She can just carry out the discussions. You guys can discuss. So the group discussion is really important, right? So please just take use of the Discord server, your virtual library. That's a really important thing. Any questions? Hello?
Doctor, how about the microbiology? How are we gonna?
Okay, so for the microbiology, Dr. Muskan is going to continue the session because nowadays what happened that Dr. Muskan was basically having her exam as well, right? Her school exams. So,
Yeah. How about the UWorld microbiology questions?
UWorld micro, as I already mentioned, from tomorrow onwards, I'm going to take the charge of UWorld, right? I'll be discussing the
Okay,
entire.
great.
And what we have decided that once the entire microbiology is finished, in the end, we are going to discuss the UWorld MCQs. We only have 60 MCQs of microbiology, right? That isn't a big deal. We can just do it in a single day as well, right? So you don't have to be worried. And thank you so much, guys, for your support in these days, because you guys know that everything was so dispersed. Everyone was so busy. Dr. Moaz, Dr. Mahi, and me as well. I was just handling a lot of things. So thank you so much for your support, and we are back at our routine. Thank you so much. Yes, do you guys have any questions? You guys can just ask, please.
Doctor, how do we join the Discord?
So the Discord, Dr. Hamza have shared the link. I'll just tell him again to share the link in the group, in the marathon group. So you guys can just join that, okay? And
Thank you.
from tomorrow onwards, please, from today onwards, just please start your discussion on Discord as well, right? You already have met groups, based on the time zones, you guys can just do discussion there. That's really important for you guys. Still, like you guys know that we have done 3 of the systems. The cardiovascular was a really big system. We did renal, which was a really important. So you can just assume that we have done a lot of course till now, right? 3 systems are big things and the most toughest systems we did, right? So you should just take use of these sessions, everything which we have provided to you guys, please, because we are just trying our best, but sometimes it's all about you, right? So it would be better today to find some study partners for you guys, just do discussion. Those who are from Pakistan, we have a lot of students from there. You can just find some study partners today. So it's going to be your today's task, right? Find some study partners, just assign some time with them for your Discord discussion and try to revise things, try to do things, try to teach things, right? So believe me, the best way to memorize things, the best way to learn things are to teach them, right? So it's a really best platform for you guys, I would say. Like, you can just take a lot of benefits from here, right? In the Discord server, just log into your Discord. Just it can be a group of 2 or 3. We have a lot of servers there, right? Hello. Okay, just give me a second. Is it better now? Hello. Okay, so we have a lot of Discord channels there. You guys can just join them, and you can just, like, sometimes this journey is like a really stressful journey. So you need some study partners, you need some helping hands, you need some, in order to avoid burnouts, you need some study partners in order to motivate you. So for that, you should please just start the Discord sessions as soon as possible, because I'm also really sad because you guys aren't there in the Discord. Like Dr. Mariam is so intelligent. She knows a lot of stuff, even more than me, right? Dr. Adonia, she knows a lot of stuff. Dr. Om, Dr. Divya. So you should be helping one another, right?
Is it open to everyone?
Sorry?
Is it open to everyone? Anyone can join those channels?
It's basically for those who are in the marathon, right? For those
Yeah.
who are, yes. So it's for those. So
Okay, and
Dr.
do you have any recordings for the cardiovascular system? Because you said we're done with that one.
So the recording, I'll share the recorded sessions. Don't worry, okay? If you need only
Sure.
sessions, I'll definitely
Yeah.
share it.
Yeah.
So, okay, so from today onwards, please, it's my request that you guys should just start these sessions, okay?
Thank you.
Okay, so let me just assign someone to be your leader and take you all to the Discord server. So who is going to be the volunteer? Who is going to be a strict mentor? Who is going to, take all of the students into Discord? Please, some volunteers. Anyone? Hello? No one is taking the responsibility. Why?
Volunteer for what? Can you please repeat?
Okay. I need any volunteer who is going to take all of the students into Discord server and just continue the sessions there by their own. But your job, the volunteer job, is going to remind them that you guys should be doing your Discord discussions.
I think most of us are not in the Discord server.
Most of you guys aren't in the Discord server?
I think so, because I'm not.
Okay, I'll just share the link today. Okay, that isn't any issue. Okay, so Dr. Muskan is going to be your mentor. Anyone else? Please, I need some volunteers.
I can volunteer too.
Thank you so much, Dr. Reem. Dr. Reem is going to be your head. Okay, all of you guys are going to respect her once she just told you that. Okay, a first. Yes.
Can be a backup too.
Okay, who else?
I could volunteer.
Margaret.
The days I'm
Margaret,
off. I could
perfect.
be
Margaret, yes, yes, Margaret. So Margaret, Dr. Adonia, who else? Believe me, guys, it's not a, I would say it's not a platform, right? It's a kind of family, right? So I need you guys to help one another as well, because that's also a really important aspect of your journey, right? Like sometimes one of the students cannot feel well, he's going to be demotivated, right? Because I'm seeing a lot of students even aren't participating in the classes as well. And that's not a good thing. We aren't here just to, take money and, you should just stay in the group, not taking classes and all. I don't need that. So for that, please, it's my request. I need you guys, some volunteers. So they should just wake the other up, right? Wake up, just study, okay? If they have any problem, just please give emotional support to one another. It's only, a time span of only 3 months left for your exam. You guys are almost prepared. Believe me. If you just follow whatever we are just telling you, there's 100% chances of getting passed, right? That's my guarantee. So that's also a really important aspect which I'm feeling is really deficit. That is, discussion sessions on Discord. That's really important because self-study is also important in this journey a lot. So if you guys are just studying in a group, that's going to help you a lot, right? Sometimes like maybe Dr. Adonia isn't feeling well, so Dr. Victoria is going to motivate her that let's come, let's do some MCQs. So it's going to be a great benefit for you guys, right? You should just interact with one another. You should just make friendship with one another, and you should just support one another, okay? And you guys
Excuse
are
me,
free.
Dr. Ahmed. Yes, I'm Dr. Mariam. So I can also help in the Discord server as well. Also, I want to say that we have also made a study group. If anyone wants to join there, we are discussing the high yield on that group.
That's great.
And there is another study group in which we are not me but the other participants also discussing the your daily tasks, and they are very dedicated and consistent.
That's
Really
great.
doing work for the 4 or the 5 hours, which I couldn't manage. So that's why I'm in another group. But I want to tell to anyone if they want to join with us in that group too, other
Yes,
than Discord.
that's great. Whoever is studying, they already have met their groups. They already are doing their tasks. All of you guys should, be aware of what's happening, right? So you guys can see Dr. Mariam is like so intelligent. She already have, find her way out, and she's going to help you. So Dr. Mariam, please, it's a request. Since a lot of Dr. Divya. Yes, Dr. Divya. Where are you? Hello.
Yes, sir.
Yes, Dr. Deva, please just do some volunteer work for the students.
Yes, sir. If Discord group is working, I'll join there. And as Dr. Mariam has told about the group, I would love to join there as well.
Okay, that's perfect. So let me mention Dr. Deva is, almost in the end of her journey. She just took 70%, more than 70% of her on her NBME. She's already prepared, but I don't know why Dr. Deva isn't helping our other students.
No, sir, I would love to help, but I was not able to find any group on the Discord or.
Yes, and believe me, guys, remember, like students from this group, from this 120 days marathon, they are going to be like someday your seniors, right? They're going to be residents helping you guys. So you should be, making bonding with each another as well. Like we have a big community of more than 100 students preparing for the step 1 in this marathon. Besides that, we have 3 groups, a lot of community, right? So just, take advantage of this community. Dr. Deva, Dr. Mariam, Dr. Adonia, soon they are going to get matched in the next match cycle, right? They're going to be your seniors. They're going to help you, make your personal statements. They're going to help you do your mock interviews. They are even going to help you when if they are residents, they are also going to help you in your interviews as well, right? Because, one thing which you should just keep in mind that it isn't all about your step 1 and step 2. Connections are really important, right? Connections are really important. Like, what the interviewers do basically, they, call up all of their residents and they basically ask them, do you have anyone in your mind who can be better for this hospital, for this program? And they basically, they basically recommend students, they basically recommend aspirants. So that's I have seen a lot of students scoring more than 270, 260, but still they do not get any match. They do not get any interviews because they do not have any connections, right? So all of you guys here are one day going to be residents. You guys are going to help one another, right? So for that, I want you guys to interact with one another as well. We have a group. We have never closed the discussion there. You can just discuss openly. If you are, if you are not comfortable in discussing in the main group, you can just make subgroups. You can just make subgroups. You can just have your friends, just push them, And a lot of students here, like Dr. Margaret, Dr. Adonia, Dr. Nahi, Dr. Divya, Dr. Aisha, a lot of students are almost in the end of their preparation, right? Are almost in the end, like they have they're definitely going to pass their exam. So they'll be helping in your step 2, in your step 3, right? Okay, so Dr. Moaz is going to join soon. So till that, let's have some conversation. Let's have some gossip. Okay. So even like believe me, like you have Dr. Moaz, Dr. Mahi, and I'm also going to soon apply for my match as well. Just pray for me as well. And you know that we are also going to help in your interviews. That's the main thing, right? So do not consider it as a, that as a course, that it's a course, it would just finish, and no. Till end, believe me, connections are going to help you, right? So we have a doctor. Let me mention about him, Dr. Rafiul Naib. He's basically, he have a lot of hospitals there in US as well, and he's connected here with our platform. So he helped a lot of our students. Okay, so let me just tell you a story, right? He was basically from one of a place in Pakistan that's called Peshawar, right? So he also was like a director of interview. Like he personally took interviews, and I was just sitting with him. He was just telling me a story. Whenever I see a person from Peshawar, so I would just tell him that yes, he's in because he's from Peshawar, right? So all of the seniors still there is like this kind of things, the connections. That's really important. Okay. And I've asked him. He just told me that we should participate in a research. He's like at a really big position there. I'll just share his LinkedIn profile. You guys can just see him. And he have also told me that I can just provide a strong LOR to the students as well, right? So those who aren't in the research project, kindly join that as well, because in the end, based on these research, like the topics are not only being viewed by our mentors, but it's also being viewed by Dr. Dr. Rafiullah as well. Okay, so he have just told me that in the end of these researches, I'm going to give a strong LOR based on that, and the LOR's letter of recommendations are also really important, right? And it's not that you can just get LOR from anywhere. You need a strong LOR, right? So I'll just share his LinkedIn profile. You can just view him, right? So please, those who aren't in the research, those who aren't participating well in the research, I'm requesting them as well to take that thing serious as well, because it's going to help you a lot. Okay. Okay. And another thing, I was just discussing it today with Dr. Moaz. Once you are just done with step 1, right? Once you're just done with step 1, so we also have like researchers position there as well, right? So after doing, if those who are old graduates, and just please focus on your step one, because step one is main criteria there, right? So you're like, you can just get a research position at Mayo Clinic. You can get research position like like Dr. Moaz have a lot of connections, right? So he can help you with that. So the main advantage for that would be that if you're applying to your residency and you're already at research positions, obviously you are going to be on the top priority, right? And not only you can get like those who want to get a match in the surgery or in the highly competitive programs, for that researches are really important, right? So what I would recommend is that doing your step one, do not waste your time, right? Just we'll just help you look for a research position. Just join that, and along with that, continue your step two and do some researches as well. Research is really important. But for the criteria for getting that research position is that at least having 5 to 6 publications, and at least your step one should be passed, right? So these are the criteria, and we can just easily help you get research position. Like Dr. Hasnan Ali is already at my clinic. We already have a lot of connections, so we are going to help you with that. So it's a kind of a good strategy, which I think no one would have told you before. It's a good strategy to apply for your match. If you are old graduate, if you have year of graduation more than 3 years, right? That's a good strategy, okay? So Dr. Moaz is going to join in a minute or two. So let's wait for him, and he's going to discuss the physiology with you guys. Okay. So stay here in the meet. Thank you for your patience. Okay. So see you tomorrow. Thank you.
Thank you.
Hello, hello. Can everyone hear me? Yep.
Yes.
Let me share my screen. Okay. Okay, guys. So today we are gonna start the respiratory physiology, right? So today we'll start the respiratory physiology. Okay, so some of these topics are really important, right? So we need to have a good understanding of it. Can all of you see my screen?
Yes, sir.
So I think this is gonna be a long lecture, right? Right. So, are you guys ready for a 2 hour lecture? If yes, then I'll make it
Yes.
2 hours.
Yes.
Else, I'll go
Yes.
for 1 hour lecture.
Yes. No.
Yes.
Okay,
Yes.
Good.
good,
Two
good,
hours
good,
is
good,
okay.
good.
Yes.
Okay, so it's gonna be an interactive session, right? I want all of you to participate in it with me as well, right? Okay, so so I think Dr. Hammer did embryology with you as well as the anatomy with you, so that is why we are gonna start from the physiology portion, right? So first of all, there are some lung indices that you need to remember, right? Why are these lung indices important? These are important because whenever a question of pathology comes to you, right, they're not just going to give you a question of pathology, right? They are going to integrate the physiology and they are going to ask you about the physiological parameters, right? So the main thing that they're going to ask is the physiological parameters, right? And the physiological parameters are going to be the most important, guys, right? They are going to be very important, right? So you should keep these physiological parameters always in your mind. Okay. So with that, let's start it, right? So first is the lung volumes, right? So the number one volume is the tidal volume, right? That's very simple, right? So what is tidal volume? So tidal volume is very simple. Tidal volume just means that the amount of air that you get in whenever you inspire, right? So whenever you inspire, the amount of air that you get in is known as the tidal volume, right? So for example, if you get 500 ml inside, like during each respiration, then your tidal volume is going to be 500 ml, right? It's very simple, right? And it's the volume that gets in during the quiet inspiration. Okay, after we do all of these volumes, I'm gonna go on a graph with on of these with you, right? And we are gonna do the graph, right? So why is this tidal volume important, right? So this tidal, okay, so before that, let's do one more thing, right? So this was the tidal volume, right? So after tidal volume, the next thing that is important is the inspiratory reserve volume, right? Next thing is the inspiratory reserve volume. So what is inspiratory reserve volume? So I told you that whenever you normally breathe, right, you are gonna take in some amount of air in inwards, right? And that air is gonna be known as tidal volume. After
Sir.
taking that normal breath, then you are gonna forcibly inhale a lot of air, right? And the maximum amount of volume that can be forcibly inhaled after normal tidal volume, that is known again known as the inspiratory reserve volume, right? So this is your reserve volume. And why is this thing important, right? Why is this inspiratory reserve volume important? This inspiratory reserve volume is important due to the
Excuse
fact
me,
that
Dr.
whenever you
Mars.
are
Please,
having
can
this,
you?
right? Whenever you
Excuse
are
me,
having
bro.
whenever you are having a problem, right? And um, whenever you want to breathe more, whenever you are exercising, then this inspiratory reserve volume is going to come into play. Again, normally you are not going to need this inspiratory reserve volume, right? Normally this inspiratory reserve volume is not going to play any role in your life, right? But whenever you are going to breathe, whenever you are going to do some kinds of exercise, right, then this inspiratory reserve volume is going to be very important, right? So that is why, so I'm going to explain it more during the COPD. Right. So when we do the chronic obstructive pulmonary disorder, I'm going to go into it in detail in that time. Right. So the next volume. Okay. So remember, tidal volume is not the. So let me tell you one thing about tidal volume. Tidal volume is not the only volume that you inspire. Right. The volume that you expire is also known as the tidal volume. Right. The volume that you expire is also known as the tidal volume, right? So for example, if you expire 500 ml, right, The air that you can expire after doing this 500 ml by forcibly exhaling, that air is going to be known as the expiratory reserve volume, right? That air is going to be known as the expiratory reserve volume. Oh, can you not see my slide?
No, we can.
Okay. So that air is going to be known as that thing is going to be known as the expiratory reserve volume. So we are done with three volumes. One is the tidal volume. The second one is the inspiratory reserve volume. The third one is the expiratory reserve volume. And the last one is known as the residual volume, right? So for example, if I say to you that uh, you try your maximum, you try your best, right? And when you, how is this possible? You cannot see my screen.
We can see.
Okay, can you see it now? Okay. So now, okay. So whenever you do your maximum and you expire the most, after expiring the most, now the volume that you get, that volume is going to be known as the expiratory. Now, for example, if you expire the maximum that you can, right? Do you expire the maximum? You try your best to push out as much air as you can, right? After that, some amount of air is going to be left in the lungs as well, and that air is going to be known as the residual volume, right? This air is going to be known as the residual volume, right? And this residual volume is very important, right? Why is this very important, right? So let me tell you one simple thing, right? So now we have two disorders, right? So all of the chronic disorders of lungs and the respiratory system, they are going to be basically revolving around two things, right? One is going to be the inspiration and the other is going to be the expiration, right? So they are going to revolve around two things, right? One is going to be the inspiration. I'm telling you again, one is going to be the inspiration and the other is going to be the expiration, right? So we are going to look at this thing in detail, right? And what is this thing, right? So we have some disorders which are known as obstructive lung disorders, right? Now I'm going into a bit into pathology, right? Because I want to link this thing with the pathology, right? So I'm going to look at the obstructive lung disorders, right? So what are the obstructive lung disorders? So remember, so guys, whenever people study the disorder, they just cram the things. They do not go into the pathophysiology of these things, right? And that is a problem, right? So what is the obstructive lung disorder? So it basically means, right, if this is your trachea, right, and if this trachea goes here, right, and then it divides into this thing here, right, and here it divides into this thing as well, right, and it goes here as well and it divides here as well, right. So it divides here as well and then it divides here as well, right. So it's dividing everywhere, right. The trachea is dividing everywhere, right. So what if I, so in obstructive lung diseases, this trachea is gonna get obstructed, this bronchi, these bronchi, these alveoli, they are gonna get obstructed, the bronchioles are gonna get obstructed, right. They're gonna get filled with slimy mucus like things, right. So let me ask you one thing, right. If they are filled with slimy mucus like things, right, what problem is the patient gonna have? What do you think, what would be the problem? Would the problem be in inspiration or expiration?
Air, air will be scratched.
Inspiration.
One second, I think my volume is mute. Yes, the lecture is being recorded. Yes, so what do you think? Would the problem be in inspiration or expiration, guys?
Inspiration.
More expiration.
Okay,
In
so
it's completely
basically,
blocked both.
hmm?
If it's completely blocked, so the problem would be in both inspiration and expiration.
Yes, so basically it's not completely blocked, so something can still pass, right? Some things can still pass.
Then difficulty in expiration.
Yes, so the
Air will be
difficulty. Yes, so let me tell you. Let me give you an example for this, right? Hmm. Okay, so if I tell you, right, so okay, okay, so right, remember, let me tell you one thing. Uh, your lungs are just like straws, right? Your lungs are just like straws, right? They are just stretchy straws, right? So if I say to you that you have a straw, right, and that straw is narrowed, right, so it would be very hard to. So and now do I ask you two things? Is it easy to suck from this straw, right? So if a straw is narrowed, right, would the problem more be in sucking or more in blowing things out of the straw? So obviously, the problem is going to be blowing things out of the straw, right? So things are not going to get blown out of the straw. It's going to be very hard to push something out of that straw. It is still going to be easier to push things in. Why? Because normally our ability to pull things inwards is stronger, right? Our ability to pull things stronger is inward. So remember, expiration is a passive process. Do you know this, guys? Is inspiration is an active process or passive process? First, tell me this.
Passive?
Inspiration is an active,
Inspiration
so
Yes.
is
must.
So
active
Active,
and
active process.
expiration is passive.
yes, so inspiration is active. So even if you are having problems with your clogging, so even if there is clogging and that is causing problems, right? The problem is not going to be during inspiration because you are still using your muscles, right? You are still using some power to get out, right? But during expiration, right? So during expiration, it's a passive process, right? And during passive process, you are going to have less amount of energy, right? And when the energy is gonna be less, right, whenever the energy is gonna be less, right, you're going to have difficulties, right? So now what if I say to you, a patient is coming to you and this patient is having problems in clogging, right? His airway is clogged, right? So a patient comes to you and that patient's airway is clogged, right? Now since this person's airway is clogged, he cannot push things out, right? If a person's airway is clogged, he cannot push things out. This is very important, right? Now since this person cannot push things out, right, what is going to happen? What do you think is going to happen to the residual volume? I want to know this from you guys.
Um, it will be increased.
Yes, so it's
Increase.
yes. So it is gonna be increased and the air is gonna be trapped. So this is the main thing regarding asthma, regarding chronic obstructive pulmonary disorder, regarding bronchiectasis. And this is the simple concept that a lot of people don't understand. Right? This is the simple concept that a lot of people don't understand. Now we are gonna do four more volumes, right? And after doing that four more volumes, then we're gonna move to some more important things, right? So now the other four things are capacities, right? So the first capacity is inspiratory capacity. So inspiratory capacity is very simple. It's the amount of maximum amount of air you can get in, right? Now I am gonna ask you guys, what is the difference then between inspiratory capacity and inspiratory reserve volume?
Sorry, what was the question, Dr. Mas? Please repeat.
Yep. So the question is, inspiratory capacity is the maximum amount of air that you can inhale in, right? Right. So what is the difference between inspiratory capacity and inspiratory reserve volume?
It's like if you inspiratory capacity plus residual volume is vital capacity. Residual volume is not taking part in breathing.
Inspiratory reserve volume is the air that can still be in the lungs after the
Mm-hmm.
normal inspiration.
Hmm. And then, so
Residual
how is
volume.
it
And
different from? So,
the capacity is the sum of two or more than two volumes. And that's why now the volume inspiratory volume is when the maximum inspired after normal titer volume. And capacity is the sum of both, the residual volume plus maximum inspiratory volume.
exactly. So if I make it simple, right? If I make it simple, let's look at this graph, right? So let's say this is your lung volume, right? And this is time, right? This is time and this is the volume of lungs, right? So I'm going to make a very simple graph, right? So first of all, when you are, so for example, during this first time, you are just sitting normally, right? So the volume is going to increase like this, right? The volume is going to increase like this. And this area, this time period is going to be known as the tidal volume, right? After that, right, you decide I'm gonna take a very deep breath, right? And you start inspiring more and more and more and more amount of air. And then this period is going to be known as the inspiratory reserve volume. So inspiratory reserve volume will start after you are done with your tidal volume, right? Inspiratory reserve volume starts after you're done with your tidal volume, right? Not before that. Okay. And the whole process, the tidal volume plus inspiratory reserve volume, is known as the inspiratory capacity, right? This thing is known as the inspiratory capacity, right? So now I told you that. Okay, so now one more thing that comes into play here is the fact that so let me tell you one thing. So the thing that is important here is, guys, during oh, so the thing that is important here is the fact that we have another sort of disorders, and those disorders are known as the restrictive lung disorders, right? So the next disorders are the restrictive lung disorders, right? So what is going to happen in restrictive lung disorders are that. So the second type is the restrictive lung disorders, right? So what is going to happen in restrictive lung disorders is the fact that now the lung is going to be so much there are different problems that can cause restrictive lung disorders, but the main thing is that the lung won't be able to expand, right? The lung cannot expand now, right? And during inspirations the lung have to expand, right? So now if the lungs cannot expand, you are going to get less amount of air inwards, right? So what physiological parameters, what volumes and capacities are going to be affected? Anyone?
Tidal volume and inspiratory
Most of,
reserve.
Yes.
yes,
Yes, so the tidal volume is going to be reduced, the inspiratory reserve
yes.
volume is going to be reduced as well,
Most of the
right?
volumes and capacity will be reduced. Yeah.
Yes, so
Yeah,
residual volume is
everything
going to
will
be
reduce.
reduced as well. So this is the
Mhm.
difference between like the restrictive lung disorders and the obstructive lung disorders, right? So now the next capacity is the vital capacity, right? So what is vital capacity, right? So normally you have a set amount of air in the lungs that you can expire, right? You have a set amount of air in the lungs you can expire. So let me give you an example. This is a very funny thing. Like yes, I would repeat that obstructive lung disorder. But before that, let me tell you one important funny thing, right? So the thing is that you guys would have seen this in the past as well. You guys would have seen this a lot, right? So normally normally we ask. So normally what do we do is that sometimes we have a bet among ourselves, right, between our friends, who can hold the breath for the longest amount of time, right? So we say like who can hold the breath for the longest amount of time. And for from this example, we can easily understand all the volumes, right? So normally during before, yes, so as kids we used to do that a lot, yes. So what did we do was that the first thing was we were sitting and we were normally inhaling here. That thing was the vital capacity. And then all of a sudden a person asked us to do this thing, and what did we do was that we inspired a lot of air inwards to get the maximum amount of air inwards. That thing was known as the inspiratory reserve volume, right? Right. So we at this point we had the inspiratory reserve volume and the tidal volume in the lungs. We had two things in the lungs, right? And now we started holding our breath, right? So we started holding our breath, right? And we had these two things inside, right? Now after that, our lungs. So we held our breath for 1 minute, right? And our body was so much oxygen deprived for 1 minute, or our body had so much carbon dioxide, that as soon as we released our nose or who started breathing again, right, body tried the maximum amount of effort to exhale every single thing out, right? So what will the body exhale, right? Now the body is gonna be exhaling, right, this inspiratory reserve volume that he used. It's going to inhale the vital capacity as well, right? And after both of these we have the third thing, which is known as the expiratory reserve volume, right? So this is the other thing that the body can exhale. So all of these things are going to be known as the vital capacity, right? So this is the maximum amount of air that can be exhaled after maximum inhalation, right? After maximum inhalation, this is the maximum amount of air that can be exhaled, right? So there are two things, right? One is vital capacity, one is expiratory reserve volume. Expiratory reserve volume is the air that you can exhale after you are after you just do a normal inspiration, right? But if you are doing a forceful inspiration, so the maximum amount of air that you can exhale after a forceful inspiration, that thing is going to be known as the vital capacity, right? Guys, this is not easy, right? I know you're going to get confused between them a lot, but whenever you get confused, whenever you don't understand anything, you can ask me a question, right? We are going to go over these parameters again and again and again and again, right? Then we have the functional residual capacity, right? Functional residual capacity, that is very simple, right? Wha- Yes, okay. So, okay, wait. Let me give you an example so it becomes easy. Okay. So, so imagine, imagine you have a balloon, right? So imagine you have a balloon, right? And this balloon normally has 100 ml of air inside it, right? This balloon has 100 ml of air, right? And if you squeeze the hardest, right, you can remove 80 ml of the air. So how much air is going to be left behind? Anyone?
20.
20. So
20.
what is, so this, what do we call this 20 ml of air that will be left behind if you try the maximum to, like,
Residual
get.
layer.
Yes, so this is
Reservoir
the,
volume.
so this is the
Residual
residual
volume.
volume,
Residual volume.
right? Residual volume, right? Now what is happening is that so normally there is 100 ml of air. Now normally someone puts little bit of air inside it, and that air is 50 ml, right? So the air that is coming into the into the balloon is going to be known as the tidal volume, right? So 50 ml air is coming. Now the total volume is 150 ml, right? Now the total volume is 150 ml, right? And again 150 ml, right? So the air that is going to go outwards, right, is going to be 50, so 100 ml is going to be left behind. So this cycle is going to repeat. But now you decide, when you do a normal inspiration, right, you know, a normal inspiration, right? So after a normal inspiration, a normal air getting into it, we are going to get 150 ml of air, right? Now, what do we do is that we now start to get as much air out of it as possible, right? And normally we can get to 20 ml, right? So now we can get from 150 ml to the 20 ml. So we are getting 130 ml of air out. What is this 130 ml of air? What is this thing known as?
Vital capacity.
Anyone else?
Vital capacity.
No, 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 no.
Dr. Moaz, can you repeat the question again,
Okay, so
please?
I'm saying that this balloon normally has 100 ml of air, right? This balloon has normally 100 ml of air, and you are putting 50 ml of air to normal inspiration, right? You're just normally putting 150, and now this, how much? So now you are putting 100 ml, right? How much air is gonna be in the balloon now? Anyone?
150.
Yes,
Closing
so you're gonna
capacity.
have 150 ml.
150.
So you
150.
Yes, so you're gonna have 150 ml of air, right? Now you decide to get all of this air out, right? Right. So what is that indices, or what does that volume is gonna be known as?
Closing capacity.
Expiratory reserve
Reserve
volume.
volume, right? So that is gonna be known as the expiratory reserve volume, right? This is important. So this is how U World and NBMEs are gonna ask you the questions. This is how they are gonna twist it for you, right? They're not gonna give it to you in the simple way, right? Because they know that people know a lot, the definitions are not gonna go that definitions, right? So this is gonna be known as the expiratory reserve volume. So that is why I want to tell you, right? But let's so
Please, can
now
you repeat that again? I didn't get that, please.
okay, okay,
Thank you.
okay, okay. Okay. So imagine you have a balloon, right? Imagine you have a balloon, right? And in the balloon, right, you have 100 ml of air, right? And you decide to get you decide to get 50 ml of air inside it. What is this volume known as? This is a normal air that you are getting in. What is this volume?
Yeah, 150 mils.
No, no. So I'm
Tidal.
asking.
Tidal volume. Tidal volume.
Yes, so this volume is the tidal volume, right? So this
Okay.
volume is the tidal volume, right? So this is the a volume that is gonna get it, right? So now how much volume is gonna be in the lungs right now or in the balloon right now?
It will be 150. 100.
Yes, so it's gonna be 150, right? Now you decide, right? So now you decide that I need to get all of this air out, and you blow the balloon to its maximum capacity. You exhale with the maximum amount of energy, right? And you decide to do it, and you get 130 ml out, and 20 ml is left behind, right? So what is this 130 ml thing known as? This is the question. This is,
Expiratory reservoir.
yeah, so this is known as the expiratory reserve volume, right?
Reserve volume.
And the 20 ml that is left behind is known as the residual
Yes.
volume, right? Wasn't expiratory reserve volume air expired after you blow out tidal air? Yes, 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 yes. So, mm, kind of, right? Kind of, you can say it like that. Mm, so I'll go into the detail of it, right? Okay, talk what is it? Okay, so that is the norm. Okay, so I'm gonna go. So I'm gonna go it into what is the 100 ml. I'm gonna tell you what is it, right? I'm gonna tell you what is it, right? Yes, I'm gonna tell you what is it. Okay, so okay, so I think this is clear, right? Now what we have is that, so I told you that, for example, 100 ml air is left behind. This is very important. This 100 ml air is very important, right? I'm going to tell you the name of it later, right? So normally you get 50 ml in, but after that you decided to get more air in, so you get 200 ml more in, right? What is this 200 ml that you're getting in now?
Inspiratory reserve.
Volume, right? And what would be the
Expiratory
inspiratory
reservoir.
capacity? Anyone?
Expiratory
No,
capacity in
inspiratory capacity. Inspiratory capacity.
inspiratory capacity would be like 50 plus 200 plus 80.
250.
250.
350.
250.
Yes. So
330 because 20 is residual.
250.
so you don't count the residual in the inspiratory capacity, right? The inspiratory capacity is
That's
simple.
why
It's the tidal volume plus the inspiratory reserve volume. So if you add both of these, right? If you add the 200 plus 50, mm, no,
250.
yeah. So it's gonna be 250, right? It's gonna be 250, right? Now, the inspiratory capacity is going to be 250. It's going to have two things, right? The inspirator is a volume. So now you have 250 ml of air coming inwards, and you have 100 ml inwards as well. So now you have 350 ml of air inwards right now, right? You have 350 ml of air inwards, right? And now you decide to blow all of it out, right? You decide to blow all of it out, right? And by the law of physics, right, 20 ml is still going to be left behind. So you blow 330 ml out, right? What is this thing known as?
vital
Vital
capacity.
Yes, so this is the vital capacity, right? This thing is known as the vital capacity, right? This thing is known as the vital capacity. So this is very important. The vital capacity is very, 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 very important, right? So know the difference between vital capacity. Vital capacity is related when you do the maximum inspiration inward, right? So when you are having the inspiratory reserve volume done, then the vital capacity is gonna come into play, right? This is the vital capacity. Okay. Now, let's go over some other things, right? So, what is functional residual capacity? So, functional residual capacity was very simple. You guys told me already what is functional residual capacity. That 100 ml of air that was just sitting, 100 ml of air that was just sitting in the lungs, one as the functional residual capacity, right? And air that was normally sitting there, that was, yes. So the formula for it is ERV plus RV, right? But from the formula it becomes a bit difficult, right? So remember, when the lung is not expiring, when the lung is not inhaling, right, it's just sitting normally, right? All the amount of air that is left in the lung is known as the is known as the functional residual capacity, right? I'm gonna do a graph and I'm gonna explain it to you, but I know in the start it gets a little very overwhelming, right? It gets a little overwhelming, right? So we are not gonna explain, not gonna go to the graph right now. Okay, any questions?
No. 'Cause- 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 No, doctor.
Okay. Now, functional residual capacity is done. Functional residual capacity is done. Expiratory capacity is done. Vital capacity is done. The last lung thing is known as the total lung capacity. It's not that useful, right? We could get it over in later, but that's not useful, right? So now two things are important. So in lung physiology, in lung pathophysiology, two things are very important. One is the one is the forced vital capacity, right? Or we also call it as the forced vital capacity something, right? And the other thing is the FEV1, right? So what is FEV1? FEV1 means the amount of air that you can exhale in 1 second, right? It's very simple, right? The amount of air that you can exhale in 1 minute is going to be known as the forced expiratory volume, right? Again, the amount of air that you exhale in 1 minute, right? The amount of air that you exhale in 1 minute, that thing is going to be known as the forced expiratory volume, right? Now we have a graph which is known as, we have an indicator which is known as the FEV1 divided by FVC, right? We have FEV1 divided by FVC. If it's 80, that's normal. If it's less than 80, there's a problem. Why? Because if it's when would it get less than 80? When the FEV1 is decreasing. And when the FEV1 decreases, it means that you cannot exhale all of the air out, right? When the FEV1 decreases, it means that you cannot exhale all of the air out, right? It means that there is obstruction in the lungs, right? So it happens during obstructive lung diseases, right? So this is the basic concept of these things, right? This is the basic concept of these things, right? Any questions till now? If not, we are going to move forward.
Is the sorry, is the forced vital capacity same as vital capacity?
Yes, it's almost the same, right? We can say it's almost the same. Yes, it can decrease with increase in FVC, but that's not very common, right? That thing is not very common as compared to the other thing. So we don't focus on that one. Okay. Respiratory. Let's wait a second. Hmm. Have to let me pull up some questions, right? So maybe we could go to do some questions on these first, right? And after doing the questions, right, then we could move forward, right? So because what is a thing without questions? Yeah. There won't be a lot of questions on this, right? But if I find anyone, I'll just give me 1 second. Hmm. Okay, so but before that, let's do some 2 or 3 topics, right? Then we'll move to the question. So the next topic is very simple. It's the work of breathing, right? So what is the work of breathing? Okay, so it's been 35 minutes, right? It's been 35 minutes. Yes, I think it's been 35 minutes now. You're welcome. Yes, so work of breathing. What is work of breathing? So work of breathing means that the amount of in energy, right, or the amount of oxygen that you need to do the ventilation, right? Right, that you need to do the ventilation is known as the work of breathing, right? No need to go into a lot of detail about it, right? No need to go into the nitty gritty about this, right? So there's a lot of factors that are involved into this, right? Now, mm, when is work of breathing high, right? When is work of breathing high, right? Work of breathing is high whenever you have some restrictive disease or obstructive disease, right? And I have tell you that there are two things regarding, so basically remember, uh, there are two kinds of resistance in the lungs, right? There are two kinds of resistance in the one. One is airway resistance, right? And the other is the elastic coil resistance, right? The airway resistance is very simple. I have already told you about the airway resistance. So, any questions about the airway resistance? Anyone, any questions about the airway resistance? Okay. Let me repeat it again if you want. Okay. So what is airway resistance? So basically, I have told you that our airway has bronchioles, bronchi, trachea, alveoli, right? And whenever air flows through them, you're gonna get some kind of resistance, right? But sometimes you have chronic obstructive pulmonary disorder, right? Sometimes you have chronic obstructive pulmonary disorder, right? Sometimes the bronchioles are very narrow, sometimes the airways get very narrow, sometimes you get slimy material that is present in these airways, right? And whenever you get these things that are present in the airways, what are you gonna get is that you're gonna have increased amount of resistance in the airways, right? And when you have these increased amount of resistances which is present in the airway, right, you're gonna get have increased airway resistance. And when the airway resistance is gonna be increased, what are diseases in which airway resistance is gonna be increased? So the diseases are obstructive lung diseases, right? And when the airway resistance is increased, you're gonna have increased amount of work of breathing, right? The work of breathing is gonna be increased a lot, right? The work of breathing is gonna be increased a lot, right? Now how can you, so this means that you are having increased airway resistance, right? So how do we solve this thing, right? Any idea?
Pursed lip breathing.
Yes, so pursed lip breathing, right? So one thing is that we do the pursed lip breathing, right? Anything else?
Bronchodilators.
Okay, so what is the physiological mechanism that we use? It's I know.
COPD, they have increased air resistance because
Muscle.
the dead space is broken down, and there's a large dead space instead of like having a larger surface area for to resist the airway breathing. That's why they
Okay.
do the
Use
Yeah.
external muscles like abdominal and
Okay, so let me tell you one thing. Let me tell you one thing, guys. Let me tell you one thing. Right now, what do we do in case of like obstructive lung diseases? Is that our body decides to use the SSA muscles. And why do the body starts to use the accessory muscles? The body uses the accessory muscles, right, to increase the tidal volume, right? Tidal volume is gonna be increased. You need an increased amount of tidal volume because the problem is gonna be in the tidal volume, right? So you increase the tidal volume, and obviously, if you increase the tidal volume a lot, it's not gonna be helpful. It's gonna be bad for you. So you decrease the airway resistance, right? So you increase the tidal volume, and with increasing the tidal volume, you're gonna decrease the respiratory rate. So we are gonna go into the concept of minute ventilation sometimes later, right? But this is what is going to happen, right? So we're going to go into the details of these things later, right? So this is basically work of breathing, right? So now there is a thing which is known as the determination of the physiologic dead space in the first state. That's not important, you can just skip it. Now what is minute ventilation? Minute ventilation is very simple. Minute ventilation means that the total volume of air that is getting into your lungs per minute, right? So did how much? So what was the thing that how much? So how much air gets into the lung in with one breath? What is known as that thing?
tidal volume.
Tidal volume, right? So just multiply the tidal volume with the respiratory rate, right? So normally the respiratory rate is 12 to 20, right? The tidal volume is 500. You just multiply these, and you are gonna get the minute ventilation. Then we have something which is known as, yes, so it's the same, like, so it's just like, so it's very similar to cardiac output and stroke volume, right? So cardiac output is equal to stroke volume plus heart rate, right? Plus into heart rate. Here we replace the heart rate with the respiratory rate, and stroke volume with tidal volume, and cardiac output is going to be the minute ventilation. Right. Now we have another thing which is known as the alveolar ventilation, right? So that means the amount of air that reaches the alveoli. Now, why is this thing important? This thing is important because in a lot of periods of time, right? A lot of times we do not get a lot of time what is going to happen is that all of the air does not reaches the alveoli, right? Some air is going to go into the dead space, right? And so if this vt is the tidal volume, vd is the dead space volume, right? So we have two things, right? If vt is the tidal volume, right? Is vt is the tidal volume, vd is the dead space volume, right? Okay, is this clear?
Yes.
Mhm. Okay. Okay, now, so this is important, right? As VT is the tidal, VT is the dead. So for in order to get the minute ventilation, we are gonna just subtract, right? VT from VD, right? And we're gonna multiply it with the respiratory rate, right? We're gonna multiply it with the respiratory rate, and we're gonna get the alveolar ventilation. Okay, so now, so let's now the next thing is lung and chest wall properties, right? So we have two things in the lung. One thing is the elastic recoil, and so guys, if you're not understanding anything, you can tell me, right? If you're not understanding anything, you can tell me, right? Wait a second, but remember one thing. So first of all, let's start from the elastic recoil, right? Let's start the first thing from the elastic recoil. So we're going to start the first thing from elastic recoil. So what is elastic recoil, right? So remember, our lungs have a tendency to fall inwards and collapse every time, right? Our lungs want to collapse at every single time, right? This thing is known as the elastic recoil, right? And at the same time, our chest wall has a tendency to go outwards. That is known as the elastic recoil of the chest, right? So our lungs have a tendency to like collapse, and our chest has a tendency to move outward. All right. Now, the thing that is happening is that uh, the at the functional
Sorry,
residual
can you,
capacity.
sorry, Dr.
Yes.
Mas, can you repeat? Can you repeat?
Yes, yes, I can repeat. Right. So remember, lung is like a balloon, right? Lung is like a balloon. Like this is a balloon, right? The inherent nature of a balloon is that it's gonna collapse, right? it's gonna it's gonna die, it's gonna collapse, right? It's gonna get all of the air out of it every single time. Okay, so it's gonna be very flat. That is the nature of the balloon. This is known as the elastic recoil. So the balloon is gonna move inward. At the same time, the chest wall is gonna move outward, right? Okay. At the same time, the chest wall is going to pull the balloon outwards, right? So imagine if a person is standing here, right? So let me do one thing, right? So let me say a person is standing here like this, right? A person is standing here like this, and another person is standing here like this, right? And they're pulling the balloon outwards, right? This is the recoil of the chest wall. They're expanding the balloon, right? And the balloon wants to crash. The balloon wants to get crushed. That is known as the elastic recoil of the balloon, right? So there is an inward pull of the lung, and there is an outward pull of the chest wall, right? So the lungs want to go inside, the lungs want to get all of the air out, right? And so what is going to happen is that if this is the chest, if this is the balloon, right? So the chest wall is going to say to the balloon, have 200 ml of air inside you, right? Okay. The chest wall is going to say to the lungs, right? So it's going to expand the lungs to get 200 ml air, right? and the balloon is gonna fight with the balloon is gonna fight with the chest wall, and it's gonna say, I'm sorry, I do not want it, right? I'm gonna collapse, right? And it's gonna get narrowed, right? And it's gonna move to like 40 ml, right? It's gonna get moved to 40 ml. Okay, is that clear? Do you get it? Okay, so the balloon is gonna get, the balloon wants to get smaller, and the chest wall wants the balloon to get high, and ultimately they reach a point of negotiation at which they say, okay, I am pulling inward, you are pulling outwards, we are going 100 ml, right? So it's just like you have two cars, right? So one is a Lexus, right, and the other is like a Ford, right? So Lexus is going in this direction at a speed of 100, right? And Ford is going here at the speed of 100. So there is going to come one point, both of these are going to be attached to each other, right? Both of these are going to be attached to each other, and then the lungs are going to stay at the same place, or the thing that is in the middle is going to stay at the same place, right? So this is known as the functional residual capacity. That was the 100 ml of air that I was telling you, right? At functional residual capacity, this thing is going to happen, right? Not clear. I don't get your point. Okay, is anyone else having problem with this?
Yeah, it's clear.
Okay, wait. I'm gonna explain it. Okay, I'm gonna explain it. Okay, so imagine there is a box here, right? There is a box here, right? And there is a car here, right? So here is a Lexus, right? And this is the north, this is the south pole. When the Lexus start driving the car, where's the box gonna move? Anyone? Where is the no, so it's gonna move to the north, right? Wait a second. Yes, so dot dot dot, it's gonna move to the north, right? So the box is gonna go to the north, right? Now what happens is that we add another thing, right? We add another car here, right? So we add a Ford here, right? And this is the south. And this starts pulling it with the same force like the Lexus is pulling it. Now where will the box stay? Anyone?
In the middle.
In the middle, right? In the middle. This middle point of the lung is known as the functional residual capacity, right? So the middle point of the lung, this is the point where the lungs want to collapse, where the lungs want to move to zero volume, right? So here the lungs want to move to the zero volume. So now I'll complete it. I will make a very good so here the lungs want to move to zero volume, right? The lungs want to collapse, right? But your chest wall at this point wants to expand the lungs, right? And the forces of both of these are equal, but they are in the opposite direction, right? So this is in accordance with the Newton's, I think, third law of motion, right? That two forces act, whenever two forces act, they are equal but opposite in direction, right? So this is the point. So at like at a normal point, right, two forces are gonna act, they are gonna act at the same thing, but they are gonna act in the opposite directions, right? So they are gonna act at the same thing, but they are gonna act in the opposite direction. So here two things are occurring, right? The chest wall is moving the lungs outward, right? And the lungs are moving inward due to their own nature, right? Because they are balloons, right? And balloons always move inward, right? Balloons don't want to have any air inside them, right? So this is what is happening, right? Now, so now you're gonna get a middle point, and that, so for say let's say the middle point is 100 ml, right? So the middle point is 100 ml, okay? The middle point is 100 ml, okay? Now, the next thing that is important is that, so now from here on we can get every single point that we want, right? We can go to every single thing. We can derive any single equation that we want at any point, and it's going to be very easy, right? How? Right. So 100 ml is the middle point, right? Now, if you apply any external force, that is going to change the dynamics, right? So, for example, if you want to exhale everything out, if you want to push more pressure of the lungs, so now if you decide to help the lungs, right? If you decide to help the lungs collapse, right? It can move to 100 ml to 20 ml, right? So this is going to be known as the expiratory reserve volume, right? But it won't go below 820, right? Because the chest wall is still pulling the lungs to some extent, and you cannot negate that thing ever, right? That is going to stay there every time, right? So now what do we do is that you help the chest wall sometimes. How do you help the chest wall? You you say to your diaphragm, can you contract? Right? You ask your diaphragm to contract, right? And whenever your diaphragm contracts, right, what is going to happen is that you are going to get something, right? You are going to get help to the chest wall, right? The chest wall is going to, so diaphragm is going to help the chest wall to pull the lungs more, right? And more air is going to come into the lungs, right? So this is known as the elastic recoil of the lungs, right? This thing is known as the elastic recoil of the lungs. Any questions? If you have any confusions regarding this, I know it's a bit confusing. Dot 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 dot. Did you get it? Okay. Yeah. Yeah. If you do still have any questions, you can see. You can ask me. Okay. So one other thing that is important is now one other thing that's very important, right? And what is that thing, right? So that thing is the fact that if we are having, right? So if a person, for say, if a person starts to have an obstructive lung disease, right? If a person starts to have an obstructive lung disease. So, for example, if a person starts to have emphysema, right, the recoil of the lung is gone. So, right, if a person is having emphysema, what is going to happen? The recoil of the lung reduces, right? Why does the recoil of the lung reduces? Because lungs have elastic fibers inside them that cause the lungs to contract and get to a smaller size, right? In emphysema, these elastic fibers are going to be destroyed, so the recoil of the lungs is going to be reduced. Okay, the recoils of the lungs, again I'm telling you, it's going to get reduced, right? And when the recoils of the lungs get reduced, what would happen to the functional residual capacity? Anyone? Will it increase or decrease?
It will increase
Increase.
because residual
Increase.
volume.
Yes, so it's gonna increase, right? It's gonna increase, right? So basically guys, this is the main pathophysiology of emphysema, of chronic obstructive pulmonary disorders that the people do not understand. It's related to the elastic recoil, right? It's related to the elastic recoil of the lungs, right? It's related to the elastic recoil. This is how elastic recoil is gonna work. Okay. Now we have another thing which is known as the compliance, right? So what is compliance? So compliance is very simple. Compliance means that if you change the pressure, right? If you change the pressure, so if you apply external force to the lungs, how much are the lungs gonna expand, right? If the compliance is good, the lungs are gonna expand more. So compliance basically simply means, in a simple term, compliance means that how much is a person good to you, right? How much of a person is helpful to you, or how much does a person listens to you or changes to you, right? So how much flexible a person is, so right. So if a person is very flexible, he's going to be very compliant. So for example, if you ask a person to pick up something from the floor, and if he picks up those things immediately, the person is very compliant. The same goes for lungs, right? If you apply a little pressure and the lungs expand a lot, it means that the lungs are very compliant, right? It means that the lungs are very compliant, right? And we need compliant lungs so that we need compliant lungs so we can easily fill up the lungs with volume, right? Yeah, so the compliance is the ability to compromise, right? So compliance is the ability to compromise, and that is why it is inversely related to stiffness, right? If a lung is stiff, the compliance is going to be low. So this is what is happening in case of restrictive lung disorders. In case of restrictive lung disorders, the compliance is going to be very low, right? Again, I'm telling you, in case of restrictive lung disorders, the compliance is going to be very low. The lungs don't want to expand, right? Lungs are very difficult to expand, right? So it's going to happen in restrictive lung disorder. It's going to happen in pneumonia as well. It's going to happen in ARDS or COVID as well. So this was the thing that was happening in COVID. In COVID, right? The lung did not want to expand, right? The lungs did not want to expand, right? The lungs were so stiff that they did not want to expand, right? And then you need to had increased work of breathing. You started using your respiratory muscles, you started using more energy, and when that thing happened, there were disastrous outcomes, right? So this was all due to compliance, right? Now in emphysema and in COPD, the compliance is going to be very low, right? The compliance is going to be very high, right? So what does that mean? It means if you apply a very little amount of energy to the lungs are going to expand like crazy. The lungs are going to expand like crazy, right? Now why is this thing important? Guys, now this thing is important due to the fact that if the lungs are so expanding so much, right? That is then a problem is gonna come, and that thing is known as pneumothorax, right? So if you apply little energy to the lungs are gonna expand so fast, they're gonna burst, right? They're gonna burst, right? The lungs are gonna expand so fast, they're gonna get burst, right? So this is one way known as pneumothorax. Okay, so this is what is gonna happen in case of a pneumothorax. Okay, is that clear? Okay.
Yes.
Okay.
Sorry, do you mean emphysema could lead to pneumothorax?
Yes, emphysema usually leads to pneumothorax. This is yes. Okay. Is that clear?
Sir, the emphysema concept with that FRV increasing, I didn't get that.
Okay. 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 So, okay. So, let me wait. Okay. So maybe I can. So maybe what we can do is we can do that again tomorrow, right? I can explain the FRC concept again to you tomorrow, right? So maybe we can keep it till here today, right? And we can do it tomorrow, right? So tomorrow is my Sunday, right? So I wanted to ask a question. Is anyone up for like a early ceremony announcement, right? So if is anyone up for a 3 hour or 4 hour class tomorrow, right? We could cover all of the physiology tomorrow. Yes. We
Yeah.
could do all of the
Yes.
physiology tomorrow. Yeah.
Tomorrow is
So
Sunday. It's a good chance.
Yes.
yes, so you can tell the timing. I think we can start at 10 a.m. EST, right? So that is gonna be 7 p.m. Pakistani time, right? So yes, I'm gonna be available, right? And we are gonna cover almost all of the physiology, right? And then we are gonna have classes in the week as well, right? So if even if we miss 1 or 2 classes in the week, it's gonna compensate every other thing, right? Okay. So okay.
Yes, sir.
Okay.
Great idea.
Sure, sure. Inshallah. Okay, guys. So take care and bye bye for today. Okay, guys. Bye bye.
Thank you, Doc. Thank you.
You're
Thank
welcome.
you.
You're
Thank
welcome.
you.
Bye bye. You're
Thank
welcome.
you.
Bye.
Thank you.
You're welcome. Thank you so much. Bye bye.
Thank you, Doc. Thank you.